Well, good morning. My name is Joe Cressy, and I'm the chair of the Board of Health. Our board secretary has confirmed that we have quorum, so I'm calling meeting 23 of the Board of Health to order. Welcome, everyone. Today's meeting is being held by video conference. City staff are also connecting to the meeting by video conference. As City Hall remains closed, the public will continue to participate electronically and can watch the meeting streaming live at youtube.com/Toronto City Council Live. And of course, I ask everyone for their patience with any delays and technical issues. I should note off the top that we have more than 20 registered public speakers. The clerk staff have connected all registered speakers to the meeting by audio, and the speakers list can be viewed online visiting the Board of Health's page at toronto.ca/council and clicking the speakers box. Although we are in different locations and meeting remotely today, the Board of Health, our Board of Health, would like to acknowledge that the land we are meeting on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. As we begin, let me first see, we have quorum here on the call. Are there any declarations of interest under the Municipal Conflict of Interest Act? If you have an interest, I'd ask now for you to raise your hand and indicate so. Okay, seeing none. We need a motion to confirm the minutes from our last Board of Health meeting on October the 19th, 2020, moved by Trustee Donaldson. All those in favor, by way of a show of hands. Opposed, if any, that carries. Thank you. Now, having caucused board members, it appears that a number of members, including many citizen members who are dealing with the COVID response in their various public health capacities, it appears that we will have quorum until about 1 p.m. And so with that in mind, given the urgent need to address all of the items in front of us, as well as our desire to hear from all those who have registered to speak, I would like to move a motion that for those speaking, public deputants, and for questioning of public deputants, that the time limit be set at 3 minutes. Of course, in questions, people can ask as many questions as they'd like, as board members up to 3 minutes, but if we are going to deal with all the pressing and urgent matters here today, I believe this is necessary. So I will place that motion. And then if I can have the video screen, by way of a show of hands, all those in favor of the motion placed? Any opposed? Seeing none, okay, that carries. So let us begin by doing an agenda review. Item HL 23.1, response to COVID. Persevering through resurgence. We have a staff presentation and speakers on that item, so it will be held down, and I would encourage members of the board to look at the supplementary report which was posted last week. Item HL 23.2, opioid poisoning crisis in Toronto. We have a series of speakers on that item, and so that will be held down. Item HL 23.3, Toronto Public Health 2021 Operating Budget Request. I have an amendment, but let me see if anybody wishes to hold down the item. Okay, if there is, so we can then deal with this quickly. So if the amendment can be placed on the screen, and the amendment for item HL 23.3 is that the Board of Health direct the Medical Officer of Health to allocate and spend any funds necessary for the COVID-19 response, and in the event that such spending exceeds the approved 2021 operating budget, to report with recommendations on seeking reimbursement from the provincial government. The budget in front of us at $345 million for 2021 is $57 million over last year's budget. And while we're asking City Council to approve that, every indication has been provided that the province will cover it, but my amendment here is to direct our MOH to spend additional funds as necessary and to seek reimbursement from the province. So with that, my amendment shall we take the amendment and the item as a package? Okay, seeing concurrence, so we'll take the amendment and the staff recommendations as a package. All those in favor? Opposed, if any? Okay, that carries. So that's then the item HL 23.4, Toronto Public Health 2021 to 2030 capital budget and plan request. Would anybody like to hold down that item? Okay, seeing none. Councillor Layton, would you like to move that? Thank you. All those in favor? Opposed, if any? That carries. Item HL 23.5, Toronto Public Health operating budget variance. This is for the 9 months ended September 2020. Would anybody like to hold down that item? Okay, seeing none, I'm happy to move that. All those in favor? Opposed, if any? That carries. Item HL 23.6, Toronto Public Health capital budget variance for the 9 months ended September 2020. Would anybody like to hold down that item? All those in favor? Opposed, if any? That carries. And then the final item is item HL 23.7, 2020 Board of Health self-evaluation. This was from February of last year, the self-evaluation. Would anybody like to hold down that item? Okay, seeing none, would somebody like to move that? Moved by Trustee Lepretti. All those in favor? Opposed, if any? That carries. Okay, so we will return to the first item. And I would just note for members of city staff and our TPH team, if you'd like to keep your videos off, not that we don't love seeing you, Gail and Gord, you guys are the best. It will just make our managing this a little bit easier virtually. Thank you very much. Okay, so we will return. We have two items on the agenda, and with great interest in many public speakers registered for both. So we will begin with item HL 23.1 on COVID. We have a detailed staff presentation, so we're going to take the staff presentation. We will then move into public speakers before going back to questions of staff. So with that, Dr. Davila, over to you.
Thank you, Mr. Chair, and good morning, everybody. To not waste any further time, we have a presentation for you here on our response to COVID-19. First half of the presentation is going to be conducted by my colleagues from our data team. I'm going to hand it over to them, and I'll do the last half of the presentation.
Okay, I think that might be my cue. Is that my cue?
That is your cue, Effie.
Thank you, Effie. Over to you.
Hi. This is the voice, and I guess I'm on video of Effie Gurnas. I'm an associate director at Toronto Public Health. Thanks for inviting us back to share more of our great epidemiology and data analytics work. So if we can go to the next slide, please. I can get started. Thank you. Okay, so just going to start us off again, bringing us back to our current counts and totals. This is the infographic that we've shared before that shares the most current numbers for our key metrics. And as you can see, as of yesterday at 2 p.m., when we learned of an additional 538 new cases, our total reported case count has now reached 35,130 cases since the beginning of the pandemic. For those who are doing back of the envelope calculations, that is a 43% increase since I was last here with the Board of Health 4 weeks ago, or just over 10,000 additional cases in that 4-week period. This infographic also shares an important update on one of the metrics we're all watching quite closely, which is the number who are currently hospitalized. And we can see here that we're aware of 176 individuals who were admitted to hospital related to their COVID illness, and 42 were ill enough to be in the ICU. Additionally, we can see that we've learned of 1,464 deaths related to COVID. I'm going to go to the next slide just to keep moving through, please. Thank you. Okay, so this here is the most recent version of our epidemic, or Epidemic Curve for Toronto, which again shows an updated look at how our reported cases became sick over time. And as per more recently, we've been taking to showing each bar as a week's worth of data. This particular epidemic curve also shows the outbreak cases, which are the gray parts of the bar, and the more community or sporadic cases, the blue parts of the bar, since January, highlighting some key time points where public health measures were introduced along the way. You can see also the recent highs in case counts that we were aware of, and a distinct second wave are also quite evident in this view of our epidemic curve. So looking more closely at the overlay dates, we do want to, that we see throughout the course of the pandemic, you can see that changes have been made at different times to respond to disease activity, whether it's increases or decreases. What is apparent from overlaying these key dates on this particular version of our epi curve is that it takes approximately 3 to 4 weeks to see the impacts of interventions. For example, we can see at the beginning of August, when Toronto had just moved into stage 3 and things were more fully opening, approximately 4 weeks later, the beginning of September, we started to see an increase, significant increase in our reproductive number, which again captures how many people each case is infecting, had started to increase to 1.3, and our cases started to climb. Not about 4 weeks later, at the beginning of October, we began to see a concerning enough surge in cases being reported to Toronto Public Health that we, on October 10th, moved into a modified stage 2 with additional restrictions. You'll see also at the beginning of November here that we've estimated our reproductive number now to hover around 1, and has been hovering around 1 since that time. However, with daily and weekly cases so high, any decline of reports over time will be very slow. What is more concerning, and is being seen also in this graph, and we'll touch upon a little bit in a few of the other slides, is the cases related to outbreaks are starting to creep up. And we will see that these are primarily driven by activity in long-term care homes. So I just want to remind us every time we see the 2 waves together on one graph that any differences in criteria for lab testing and case finding, or the ability to detect cases, does impact how we interpret the data. So let's go to the next slide, please. Okay, so this slide here is one that uses modeling. We introduced the Board of Health to that a couple of meetings ago, and excuse me, was developed by our research colleagues at York University's Lab for Industrial and Applied Mathematics, Dr. Wu and his team, and we thank them for this. And this model and the output of it shows data up to October 25th, 2020, so uses case data up until that time, and what is called a transmission dynamics model for COVID. So in simple terms, it looks at different states of illness and how population moves between these different buckets of states from being fully susceptible all the way to being ill. I won't go into the specifics, but I will draw your attention to what it is showing us about changes of the average number of contacts each person has had per day in Toronto over time. And that's the main takeaway we wanted to use this figure to share. What you can see is over the course of the pandemic, contact rates and the amount of contact each person has had have reflected some of our closures and public health interventions, from high rates early on to much lower rates of contact during the lockdown periods and some of the periods with higher restrictions. And if we could look right near the far right of the curve to the more recent times, we can see that once we went into the modified stage 2 on October 10th, our contact rates, which have been creeping up to an average of 7 per day, according to our model, ended up going back down to 4.8 per day. So really the takeaway here for us is that there is evidence that we have been adapting our behavior since the October 10th measures were put into place, resulting in a drop in the average number of cases. And while we've had some high case count dates in the last while, we can look at this model to understand how it is that despite these counts in recent periods, we've not seen the explosive and exponential growth that has been recorded from other jurisdictions in their second waves, especially parts of Europe. We've not seen those so far in Toronto. Given the critical point we're in, it is essential that we do continue with the restrictions in order to sufficiently curb any more virus spread. So next slide, please. So here we're switching to a view that's familiar to this group, and this is the neighborhood view again. And this map shows the data that was introduced to the Board of Health last meeting by my colleague Sarah. And this shows the percent positivity and captures the week, excuse me, with the most recent complete data that we have, which is the week ending on October the 31st. Excuse me. What we can see here is that the percent positivity rates across neighborhoods do vary. So the darker the blue, the higher the rates. And we've highlighted the 3 neighborhoods with the highest percent positivity for the given week that has the most complete data. And what we wanted to show here is that while each of these neighborhoods have high percent positivity, that the supporting indicators, which we touched on last time, including testing rates and the actual case rates of COVID, also need to be taken into account to understand what is happening in each neighborhood. So I will just quickly highlight a couple of them here then. In Black Creek, for example, we can see that there are high case rates, high percent positivity, and while previously the testing rates were below the Toronto median for most of September and October, we are now seeing that the testing rates have gone back up, and now allows us to look at the case rates as truly reflective of virus spread, as opposed to requiring more testing alone. If we look at Thorncliffe Park, in contrast, we can see that the percent positivity is high, almost 12%. Case rates are high. However, the testing rates are low when you compare them to the rest of Toronto. This would suggest that for Thorncliffe Park, they could benefit from increased testing in order to quickly detect cases and notify close contacts, to further promote self-isolation for disease reduction and transmission reduction. I will remind everyone that if you wanted to see how specific parts of the city are impacted, to visit our dashboard where you can see all of those different metrics that I just mentioned, the percent positivity, the case rates, and the testing rates. They're all on our dashboard. The next slide, please. Okay, so we're switching our view to another way to look at our virus, and this is a heat map of age groups and their specific positivity rates across time. These are fairly recent data for us, and we wanted to share them with you today. And so what this shows is that where the color is darker, the percent positivity is higher. And just quickly to make sure we're reading this all the same way, from left to right horizontally is time. So as you go to the right, it's more recent time. And top to bottom is age group. So the youngest age groups are at the top, and the oldest age groups are at the bottom. And so what you are probably seeing from the darkest of blues is that the age groups in 14 to 17 years and 18 to 23 are, first of all the age groups are increasing, but those age groups are the highest in the most recent times. And so, as I just mentioned with the maps, in order to really bring life to this particular metric, we do need to look at the case rates in those same groups, and we need to look at the testing rates. They're not provided here, but I can confirm that when those are considered, these age groups, the 14 to 17 specifically, is an increasing age group and is starting to see increased virus activity or case reports, certainly. And so as this age group does provide support for some of our frontline jobs that may be exceedingly exposed to virus circulating in the community, this is not entirely unexpected. We also know that teenagers are the perfect or imperfect balance of independence and socializing, which certainly could also increase risk. And we can tell you that our source of infection information available for this age group does confirm that contact with a close case is the predominant way they are becoming infected, and that increases are not explained by outbreaks. I raise this specifically because we all know this age group is in school, and yet there is no evidence that they are responsible for the circulation of COVID in that setting in any notable way. It's also important to note that this age group is one that is less likely to suffer severe effects of illness and end up in hospital. So next slide, please. Okay, so we've moved to this view of age groups across time. We can see with this line graph that case rates by 10-year age groups have been changing and increasing across time as well, just as the previous heat map had shown. I did want to point out an increasing trend here, which is that our older age groups, our 90 plus specifically, thank you, just want to see that, sorry, has been increasing quite dramatically in the most recent times. And in fact, the rates for this group have not been this high since April. What is not shown in this slide is that if we were to only look at the non-outbreak cases, because that trend I just described is mostly just explained by institutional outbreaks, that the same vulnerable groups, so those older age groups that are not part of an outbreak, do fall to the lowest rates, and the highest age group that percolates back up in terms of rate is the 20 to 29-year-old age group, who has really been the highest, who's had the highest rates through most of the second wave, or pretty much since the stage 3 reopening. So I'm just going to go to the next slide, please. Thank you. So this is my last slide, which is trying to just bring back a few of the points together that I've made so far. And this particular one summarizes what we know related to settings that are contributing to our outbreak cases. And so you can't see this here, but I can give you the counts that since August 1st, we've had 306 confirmed outbreaks, and this shows how they're distributed over time, that are linked to 2,342 cases. And what is clearly happening here and is concerning is the increase in the institutional setting related cases, so the blue parts of the bar. And again, the furthest right part of this graph does have a delay in reporting, so that's not complete data in that bar right at the very end. So I did want to say that although that is one of the key stories in this graph, that I wanted to also focus on our on information related to keeping our schools safely open, and the fact that we've had this this focus in the last few reports. And I wanted to share that during the same time period that there have been 60 confirmed outbreaks in schools, and that they have accounted for 200 cases. What we've learned is that there have been no more than 9 cases at any given outbreak. In fact, when we look at all the outbreaks taken together, while schools have accounted for 20% of the outbreaks, they've only contributed 8.6% of all the cases during that same time. So for us, this further suggests that infection control measures are working in schools, and the increase in case reports in our communities would certainly increase the probability that an infectious child or a staff member could arrive at school at any time. However, this looks like this has been successfully contained so far. We do believe this is in part a reflection of our close partnership with the schools and school boards. It also reflects our outbreak response teams and their work with each school to investigate each and every case. And we certainly have benefited from the provincially funded temporary TPH nurses to support schools. Unfortunately, in contrast, if we were to focus on the long-term care homes and the retirement homes, we do see that the increasing numbers are also reflected in the proportions. So while 20% of our outbreaks are in the setting, they account for 61% of our cases. And certainly this is concerning after what we all experienced and saw in the first wave, that these settings with our most vulnerable individuals did result in the majority of hospitalizations and deaths. This will be an ongoing challenge, as we also know that it is very difficult to keep the virus out of these settings when it's circulating at high levels in our broader community, and this will be an important challenge for the fall for us. So with this slide, I am done my part of the presentation and I will hand it over to my colleague, Sarah Collier, to take it from here. Thank you.
Thank you, Effie. I'm going to take a few minutes today to take you through some of the updates and findings from our work on COVID-19 and the social determinants of health, mental health, and well-being. So if you could just move to the next slide, please. On May 20th, Toronto Public Health started asking those with reported COVID-19 infections about their Indigenous identity, ethno-racial group, income, and household size. On November 6th, Toronto Public Health released an update on race and income, now including a time trend of findings. You can find more details on data collection, the limitations, the findings on our website, and so I would encourage you to look on our website for the full list of updates. But I just wanted to highlight a few key results here. So 79% of people with reported COVID-19 infection identify with a racialized group, while racialized groups comprise 52% of the population. The same ethno-racial groups continue to be overrepresented, as we can see in this slide. In this graph here, the gray bars represent COVID-19 infections in each ethno-racial group, while the green bar represents the percent of the population that the group makes up in Toronto. According to our new analyses, the size of the disparity in COVID-19 rates has reduced over the past 4 months in Arab, Middle Eastern, and West Asian people and Latin American people, but the situation for Black Toronto residents has not improved. 24% of cases are among Black people, despite making up 9% of the population. Next slide, please. 30% of the population in Toronto lives in low-income households. This is in itself is a sobering statistic and one that I have unfortunately had to present many times. This slide highlights that generally people living in lower income households are overrepresented and people living in higher incomes are underrepresented in reported COVID-19 infections. Next slide, please. With these findings in mind, Toronto Public Health is continuing to move forward on our path to report on indicators that measure and monitor equity. At the conclusion of the October 19th Board of Health meeting, TPH was requested to consider adding equity indicators to our monitoring dashboard. So I just wanted to give a brief update of where we are with that. The goal of the equity indicators is to monitor disparity in COVID-19 infections and guide actions needed to bring all parts of the city to a minimum threshold level. So TPH is working to develop a set of indicators that are clear, that serve the communities most impacted, that are linked to action, and are sensitive to trends over time. As you heard in the report we presented at the last Board of Health meeting, a key message from our community consultations was the importance of engaging with community on how best to communicate and share data. So developing equity indicators is a great opportunity to ensure that our equity-related COVID measures are supportive and reflect community experiences, that they can inform constructive action, that they do not stigmatize or cause harm. So we will be discussing options with community stakeholders to get early input on how to ensure that our equity indicators meet these goals. Next slide, please. So since early in the pandemic, Toronto Public Health has also been monitoring a number of indicators related to health outcomes that are outside of the virus itself that could be impacted by the pandemic, and this includes mental health. So we have observed that in Toronto, mental health and addiction-related help seeking in the emergency department has decreased during the first wave of COVID-19. However, help seeking from virtual and telephone supports has increased, both in large referral agencies and local providers. So these agencies are reporting that there's an increase in concerns related to depression and anxiety, in particular around isolation and loneliness, physical health, and the availability of services. Next slide, please. So TPH has engaged a polling firm to survey a sample of Toronto residents about specific ways that the pandemic has impacted them. The Toronto Public Health COVID-19 survey was conducted between October 20th and 30th of this year on a sample of Toronto residents. Respondents were asked about the specific ways the pandemic has impacted them and some of their behaviors. So we're just beginning to analyze these data, but I wanted to present a few really high-level findings that relate to the pieces of work that I'm discussing here today, including mental health. So in the poll, respondents were asked how their current mental health and well-being compares to mid-March, which is the height of the first lockdown when non-essential businesses and schools were closed. And so if we look at the graph on the left-hand side here, we can see that Toronto residents are now more likely to say that things have gotten worse. That's the 33% in orange, then better, which is the blue section, and just under half are saying that there's been no change in their mental health. I would like to draw your attention to the box on the right. So if we're looking at this table, the left-hand side is the response to the question about how people would rate their mental health compared to mid-March. So we see here as much and slightly better, about the same, and slightly and much better. So these responses were stratified by the respondents that describe how they describe their overall health. So either excellent, very good, good, fair, or poor. And if we look at the boxes that are highlighted in yellow, we can see that those who describe themselves as having overall fair or poor health say that they're doing worse during this time, while those with excellent or very good overall health say that they're doing either better or feeling about the same as they did in March. So this is really highlighting that this pandemic is not impacting us equally. Next slide, please. So during a previous Board of Health meeting, we heard interest in the mental health of parents and caregivers. So I wanted to pull together this slide for you and some of these early findings again from the poll. Earlier in the presentation, Effie described how schools are doing in terms of cases and outbreaks. Even though we've seen low numbers of outbreaks in schools, we know that parents are worried about the pandemic and what it will mean for their school-age kids. So if we take a look at this graph here, again, polling data collected in October, we can see that 77% of caregivers, of the caregiver respondents, agree that they were stressed about the potential impact that the pandemic would have on their child's education. So we recognize that this has been very hard on people, even extremely challenging for some. And the preliminary data that I've just provided is really just data points that speak to some of the assumptions that we've had all along. And I just have one last slide, so if we could move to the next slide. Again, this is from the public poll that Toronto Public Health conducted. Some very preliminary analysis. Again, the bar graph is showing that there is some level of agreement from about 90% of respondents that we do need to take the necessary measures to control the spread of COVID-19. And so on that note, I would like to turn it back over to Dr. Davila to finish the presentation.
Thank you, Sarah, and thank you, Effie, very, very much for that excellent presentation, both of you, on all the data. I will take us through the final stretch of the presentation. And this is to tell you a little bit about the context within which all these circumstances are happening and where the data occurs. So as we know, the Ministry of Health recently released an updated version of a now, I think, well-publicized COVID-19 response framework. As you know, the framework does categorize public health unit regions into different levels based on the local epidemiology of COVID-19 and specific indicators around health system capacity and public health capacity. Just moving to the next slide, to be mindful of time, we know that as of Saturday, the province did move Toronto into the red zone, or the control level of this new framework. However, that being said, in our estimation as Toronto Public Health, we felt that there were additional measures that were required over and above that which is spelled out within the red zone of the framework in order to best protect the people of Toronto and their health, and to mitigate COVID-19 spread and its impact on the people of Toronto. So in particular, what we did was that we took the step of making strong recommendations, particularly around social gatherings, as you'll see here on the slide, limiting activities to the greatest extent possible to that which is done with members of your household, people that you live with, and perhaps with one or two essential supports, particularly for those who live alone. We had some very specific recommendations and instructions made towards workplaces and businesses, also all aimed towards reducing COVID-19 spread, whether it's working from home wherever possible, looking at heating and ventilation systems to ensure that they're in good working order, and ensuring that measures are in place to optimize occupational health and safety measures and infection prevention and control measures in order to really mitigate the risk that's presented by COVID-19. So these are the kinds of strong recommendations and instructions that were provided for over and above what's articulated in the red zone of the framework. Turning to the next slide, though, there were some other measures that needed to be taken in our estimation to control risk and to mitigate risk. And these additional measures required the issuance of orders under Section 22 of the Health Protection and Promotion Act. So in particular, those orders were issued in order to restrict dining and to continue the prohibition on indoor dining, a known area of risk given that it fits the 3 C's, that closed space, close contact, and crowds, particularly without a mask. Hence, it's an environment that gives rise to risk. As well, the order moved to ensure that meeting and event spaces remain closed and casinos, bingo halls, and other gaming establishments. And it also extended a prohibition on indoor group fitness and exercise classes. Again, through our experience and through the literature, known risks for COVID-19 transmission. The final component of the order adds a prohibition onto hookah lounges and their operation. And again, this is also from a COVID-19 risk mitigation perspective. There is no risk associated with those facilities. Turning to the next slide, just a little focus on long-term care homes. You'll have seen through the data that Effie presented so clearly that there are challenges. There were challenges in wave 1. There continue to be challenges in this resurgence period within long-term care homes. The province did launch a commission to investigate the spread of COVID-19 within these environments. And we at Toronto Public Health had the opportunity to provide information on the situation here in Toronto and recommendations to the commission around what might be done now and in the future in order to better mitigate risk of COVID-19 and frankly other infectious diseases from impacting both residents and staff within these settings. The final report of that commission is not expected until the spring of next year, but we believe we had a very good discussion with the commission, and I hope that we were influential in terms of their thinking and ultimately the recommendations that they come forward with for long-term care homes. The next slide, just brief summary and a little bit of a highlight on what's happening with respect to COVID-19 vaccine. You'll have heard that the city has established a COVID-19 immunization task force co-led by us at Toronto Public Health, and in particular under the leadership of Dr. Michael Finkelstein, one of my colleagues and Associate Medical Officers of Health. As well, we have representation from and leadership from Toronto Fire Services, in particular Chief Jim Jessup, Acting Chief Jim Jessup, who's covering now for Chief Peg, and Chief Gord McKechnie as well from Toronto Paramedic Services and our colleagues at the Emergency Operations Center. This is a Herculean effort. It is a massive, massive undertaking. There are roles for all 3 levels of government to play. Those are articulated on the slide here. In the interest of time, I will not belabor the point, but suffice it to say that I believe we're in good hands with our immunization task force here at the city. There are components and significant components that need to be managed at the federal level and at the provincial level. We are certainly seeking to be as influential as we can be with respect to those orders of government. But from a city perspective, I would assure members of the board that we are working very hard with our partners to make sure that everything that we can do and all that's under our control is as well managed and as prepared as we can be for when a COVID-19 vaccine is available for use and deployment. A little bit more on the vaccine is on the next slide. We know that there are over 200 vaccines in development worldwide. This was as of October. Our expectation, and certainly there's lots of hope on the horizon that the first doses of vaccine could be delivered in that first quarter of next year. We know that there are many conversations happening. The expectation is that the earliest supplies of vaccine would be administered to highest risk, populations, specific subpopulations identified by the province. And it will take time before broader public access will be available. You likely have heard, it was well publicized in the media, that vaccine companies are having some success with their early trials. Pfizer in particular announced just a few days ago that their vaccine appears to show good effectiveness, high level effectiveness, 90% in particular, 7 days after the second dose of vaccine. And today in the news, our Moderna is reporting a 95% effectiveness 2 weeks after the second dose of vaccine. So certainly lots of hope on the horizon. And we are looking forward to that, even though we recognize that the administration of the vaccine is a significant undertaking. The next few slides, I won't linger on. They are all about the recommendations in the report. My hope is that the report itself and the presentation gives you a sense as to why these recommendations are being put in front of you for your consideration and your deliberation. So I won't go over each of the recommendations here in the interest of time. There's one more slide of recommendations there. I will, as I often do, take this brief moment that I have the microphone and the camera to once again just say to the board, COVID-19 has been an incredible challenge to all of us as a city, as a society, and certainly to those of us at Toronto Public Health. I look around, the teleconferences that I participate on, I look at my email that's going all the time, and I see that my colleagues all throughout public health, Toronto Public Health, are really doing heroic work every single day. And there is not a break. It doesn't matter whether it's Saturday or Sunday, they are just at it all the time. So I just want to take this moment yet again to acknowledge all of our team, our public health inspectors, our nurses, our doctors. Those are just a few. In every role, in every capacity, in every directorate of Toronto Public Health, everybody is really just working flat out, doing their very, very best to manage what is truly an unprecedented challenge. And I simply cannot say thank you enough times for all the work that the team at Toronto Public Health, the incredible team at Toronto Public Health, is doing. And I just would hope that you join me in that thanks. I do think that they face no shortage of challenge. But I continue to be inspired and amazed at the ability of our team to meet whatever challenge is placed in front of them. They continue to just keep digging deep no matter what, and providing the best service available. So to the team at Toronto Public Health, to all of you, regardless of what role you're in, what position you hold, what directorate you hail from normally, whether you're working on the ground, at home, in front of a computer, in front of a client, whatever it is that you do, thank you for all that you do. So with that, Mr. Chair, I'm going to turn it back to you, and we'll continue on.
Well, listen, and before we do carry on, let me, on behalf of the board, thank you, Dr. Davila, along with your entire 2,000 plus strong TPH team, for the determination, for the tireless work, and most importantly, for the compassion in which you and your team do this every single day. It's that compassion that will get us through this, so thank you. So Sarah, Effie, and Dr. Davila, Eileen, exceptional as always. Members of the board and members of the public, you saw a taste of the exceptional bench strength that TPH has there in that presentation. We're going to go to public speakers. We have 5 registered public speakers on this item, and then we will move it into committee for questions. Speakers, you'll have 3 minutes. I'll give you a heads up with about 30 seconds to go, and then there will be a time for questions. Our first speaker will be Julian Bayard, and then so that those know, after we have the MPP for Humber River Black Creek, Tom Rakocevic, followed by Faisal Hassan, the MPP for York South-Weston. First, do we have Julian on the line? We do. Julian, can you hear me? Do we have you there, Julian?
Yes. Can you hear me?
Yes, we hear you loud and clear. Julian, you'll have 3 minutes.
Connection seems kind of poor. Can you guys hear me?
We can hear you fine. You'll have 3 minutes. You can begin when you're ready.
All right. Well, okay. Sorry, I'm having trouble hearing you, but I will assume that you guys can hear me, and I'll just proceed.
We hear you loud and clear. Please go ahead.
Great. So the last time that I spoke at one of these meetings, I had questions about the scientific basis for your policies, and I was quite shocked that after quoting from the findings of the government's own scientific advisors, which appear to contradict what the authorities and politicians have told us, the response was total silence. You people were unwilling to spend even 5 seconds addressing any of the questions that I raised. And I couldn't believe it. This was after I listened to people congratulating themselves for their so-called data-driven and transparent process. This is not transparency. This is not accountability to the public. This is contempt for the public. And it does not seem to be data-driven because you seem indifferent to questions about the data. Today, I'm going to ask about a different scientific issue. Your PCR testing system, which has been widely criticized for some time now, it seems, by researchers. I will read from an article in the New York Times, August 29th. Quote, the PCR test amplifies genetic matter from the virus in cycles. The fewer cycles required, the greater the amount of virus or viral load in the sample. In 3 sets of testing data compiled by officials in Massachusetts, New York, and Nevada, up to 90% of people testing positive carried barely any virus, a review by the Times found. And they go on to explain that this means up to 90% of those tests, at least, these were so-called positive results. These may have been people who cannot infect anyone and who are not even infected, but just have minute quantities of a remnant virus, possibly from many weeks earlier. Here is the Oxford Center for Evidence-Based Medicine. Quote, even if the PCR test only detects true positives, it remains to be seen whether the person can infect others, or even if the virus is still infecting the very person carrying the virus. Insufficient attention may have been paid to how PCR results relate to disease. The relation with infectiousness is unclear, and more data are needed on this. If this is not understood, PCR results may lead to restrictions for large groups of people who do not present an infection risk. So these are scientists from Oxford University who argue that it's simply unknown whether these kinds of test results actually represent a risk to public health. Now,
Julian, you're just coming up on 3 minutes, so I'm going to ask you to conclude in a sentence or two, please.
My question for today is, how do you know that your so-called case numbers are a reliable measure of any kind of health risk? How do you know that?
Thank you very much, Julian. I will now open it up to see if there are members of the board who have questions of you. The way with this works is we receive a deputation and then we see if there are questions for you. Turning to members of the board, are there any questions for Julian? Seeing none, Julian, thank you very much for your deputation and for joining us today.
I asked questions of you. Do you have any answers to my questions?
Thank you very much. I'm afraid in the way this works is we have questions for you, and we saw none.
No,
thank
I
you.
asked you questions. This is my
Mr. Clerk,
only
I'm going to have to
opportunity.
move to the next speaker now. This is the opportunity again for members of the public to speak to the board, and if we have questions for you. Our next speaker is the Member of Provincial Parliament for Humber River Black Creek. That is MPP Tom Rakocevic. Tom, do we have you on the line?
Yes, I'm here.
Welcome, Tom.
Can you hear me?
We can hear you loud and clear. Tom, thanks for joining us at the board. You'll have 3 minutes when you're ready, sir.
Great. Good morning, everyone. I'm Tom Rakocevic, Member of Provincial Parliament for Humber River Black Creek, and I appreciate the opportunity to speak with you this morning. I thank Toronto Public Health and its board for their important work in keeping us all safe. The latest modeling data released by the province of Ontario shows that by the end of December, without immediate intervention, the province of Ontario will see more than 6,500 new COVID-19 cases per day. According to the modeling data, we could see more than 400 people in intensive care units across Ontario. Based on these numbers, it is clear that the Ontario government must take action. Doing nothing is not an option. People's lives are depending on it. The one-size-fits-all approach that the Ontario government has employed so far to stop the spread of COVID-19 in some of the hardest hit neighborhoods, like many in my riding, simply will not work. If we want to have any hope of reversing this trend, then the Ontario government needs to provide direct funding to public health units like Toronto Public Health for targeted resources to fight the pandemic in the communities that have been hardest hit by COVID-19. These calls are not new. They are something that I, my Ontario NDP colleagues, and local community health organizations have been urging the Ontario government to commit to for months. Despite these calls, the Ontario government did not include any new funding for public health units in their 2020 budget, which they just released over a week ago. According to Toronto Public Health data, neighborhoods in Northwest Toronto, like in my community of Humber River Black Creek, have been hardest hit. Many neighborhoods in my community have had a positivity rate of more than 10% amongst those who have been tested. This is due to the socioeconomic determinants of health and the very structure of our communities. Data from Toronto Public Health also shows that nearly 80% of COVID-19 cases in Toronto up to September 30th were amongst individuals who are racially marginalized. I want to thank Toronto Public Health for their leadership in releasing this data. Many residents in Northwest Toronto, again, come from racially marginalized communities and are low-income and essential workers or frontline health workers. They work the kind of jobs where they simply cannot work from home. The very nature of their jobs put these residents more at risk of contracting COVID-19. Many live in small, multi-generational homes where many different languages are spoken. If any of these residents were to be infected with COVID-19, it can very easily spread to the rest of their household. This is why one important item that for months community health organizations and I have been asking for is to fund and establish community liaisons to fight COVID-19 on the ground. These individuals would ensure that their information reaches everyone in a timely way in their mother tongue. The more that people are able to receive and understand the information, the more people will be able to take the necessary action to slow down the spread. Last month, I asked the government this at the Select Committee for Emergency Management Oversight, and in fact, the Solicitor General said that the suggestion was in fact reasonable. But we have yet to see a single dollar put towards community liaisons by the provincial government. As I said earlier, just over a week ago, they had an opportunity to do so in the budget, but they simply chose not to. I came here today to once again repeat my call to the provincial government to provide the direct funding to public health for the targeted resources like community liaisons that are needed to help flatten the curve in the communities that have been hardest hit by the pandemic. The provincial modeling data shows that we can no longer wait. The Ontario government needs to step up now. Our communities are counting on us. Thank you.
Thank you very much, Tom, for that. Are there members of the board with questions for MPP Rakocevic? Questions from Councillor LongTerm. Councillor, you'll have 3 minutes when you're ready.
Thank you very much, Chair, and thank you, MPP, for your deputation. I could hear the frustration in your voice, and I'm sorry that this has been such a difficult process for yourself and the community that I know you represent. I know you work very hard to represent. Obviously, the Board of Health has to make appeals to the province. This is not something we can do without the provincial participation as well as cooperation. But I find it a little bit troubling that you're here at the Toronto Board of Health hoping to reach the province. Is there anything specifically you would like us to table at this meeting to support your work at Queen's Park?
Thank you so much, Councillor. Well, first of all, I think Toronto Public Health are doing an excellent job in fighting this. And, the official opposition and myself, we're taking every opportunity to push for more direct funding to Toronto Public Health. As we know, over $1 billion was cut in a recent budget prior to this one from your unit and public health units across the province. If you'd like to table something to amplify the call for community liaisons and ask for the establishment and direct funding from the province, that would certainly be helpful in joining your voice to ours and those that are calling for more direct funding to help you battle COVID-19 here in Toronto.
And just so I understand, your request for the community liaison table or the establishment of this working group, that was formally submitted to the province, is that correct? And what does that formal submission and communication look like?
So it has been brought up in various different forms in legislature, as well as the Emergency Oversight Committee, of which I sit on that board, and it's been asked of them directly. So it's been requested multiple times in different forms. They have said that it's reasonable, but they have not put any dollar figure to supporting it. So it seems that in principle, people will agree with this, but the government is not moving to make it a reality. We've seen some form of that with local health groups like Black Creek Community Health Center that are doing an excellent job locally in fighting COVID-19. But what they need is more direct funding. So if you're able to as well join your voice to this and make that request of the provincial government, I think it would be very helpful. It's just about putting voices out there.
Thank you. Thank you very much, MPP.
Thank you so much.
Thank you very much, Councillor LongTerm. Are there any other questions? Okay, seeing none. Thank you very much, Tom. Our third speaker on this item, and as a heads up for afterwards, our third speaker, is Faisal Hassan, the Member of Provincial Parliament for York South Weston. And so that you're aware, the speaker after is Josh Fullen from Maximum City. MPP Hassan, do we have you there?
Yes, I am here.
Welcome, Faisal. When you're ready, you'll have 3 minutes. Thank you for joining us today.
Thank you. Thank you for the opportunity to speak this morning to the COVID-19 response and how, in particular, it affected and continues to affect my riding of York South Weston. It has been said that your postal code matters as much as your genetic code when it comes to being hit by COVID-19. Dr. Tressa Tam suggested that where you live or where you don't have a home is a critical factor affecting health. Dr. Tam's recent report on COVID pointed out that communities like mine, where lower income and racialized workers often don't have the luxury of working from home, are at a much higher risk. York South Weston is home to many frontline essential workers, BSWs, nurses, cleaners, service and transit workers are those who have relied on to continue working throughout the pandemic. Those workers, along with socially and economically disadvantaged groups, seniors, women, and disabled people, are bearing the full brunt of the pandemic. It takes all three levels of government working in coordination with each other to effectively protect citizens and deal safely with this pandemic. I thank Toronto Public Health for facing the challenges task of navigating this crisis and trying to work with provincial and federal levels to meet the needs of communities. As Member of Provincial Parliament, my office has been hearing the troubling stories of community members and businesses struggling through the COVID pandemic. Our office has tried to assist the best we can. And as an MPP, I have been advocating for the changes I believe have been needed. That requires communicating concerns with the federal, provincial, and municipal levels of government. Many lessons have been learned, and the work continues as clearly we are in the middle of a devastating second wave with record COVID case numbers being recorded. I would like to touch some of the difficulties my community has faced. The return to school plan by the provincial government was very poorly planned out, and September seems to arrive as a surprise to them. Despite community and official opposition calls for small class sizes were ignored. We have classes with 25 and 30 children cramped into older schools with improper ventilations. The state of many schools were already in disrepair from years of neglect in the funding by this and previous governments. Case numbers are high nonetheless, and York South Western had the unfortunate status of having one of the first school COVID breaks in the GTA. Schools continue to be a source of outbreak with the staff and students affected. The need to investment in proper ventilation in many cases has simply not happened. When it comes to flattening the curve, the COVID curve, the need for accessible and convenient testing is an obvious one. I don't know if I would have enough time, but I have distributed my speaking notes to all of you, Chair. I know you said 3 minutes, and I don't want to also, considering your sensitive timing, should I stop there or should I continue?
You're just over 3 minutes, and so if you have a final sentence you'd like to wrap up, please go ahead. With that, thank you very much, MPP Hassan. Are there members of the board who have any questions for MPP Hassan? Seeing none, thank you very much for joining us here today, Faisal. Our next speaker, if we have him on the line, is Josh Fullen from Maximum City. Josh, do we have you on the line?
Yes, I'm here, Chair.
Welcome, Josh. You know the drill. You've been here before, so when you have 3 minutes, and you can begin when you're ready.
Thank you, Mr. Chair, and thank you to the board for this opportunity to speak on a very busy agenda. As most of you know, my organization has been leading a pan-Canadian and Toronto-based study of the behaviors, school experiences, and well-being of children and youth since March. And the goal of the study is to measure the downstream impacts of COVID-19 conditions on secondary health and well-being. What's unique about our study is that it listens directly to kids and teens. So they are the respondents in our survey work, and they tell us sort of what their experiences have been like. We've had 2 waves of data collection, one in the spring, which we've reported on here and at other bodies, one in the fall, which I'm going to give you a quick update on very shortly, and then another one in spring of 2021. And the main healthy movement behaviors, which I'll speak to in a moment, that we measured are physical activity, screen time, sleep quality and duration, and time outdoors. So since I last spoke to this board, there's one notable new finding from the spring data set, and that is that the spring data shows strong correlation between not maintaining physical activity levels and declines in subjective well-being tied to negative emotions during the first lockdown. So what that means is if you kept up or increased your physical activity during the lockdown, your self-reported mood was better. And there is an academic paper in progress that speaks to those findings. I want to speak today mostly to the 4 notable findings from the new data set. And this is early analysis of a survey we conducted across Canada and within the Toronto CMA in October. So number 1 is that compared to the spring, children and youth are reporting moderate improvements in their healthy movement behaviors. There's still a significant proportion reporting a decline in those 4 healthy movement behaviors that I spoke to: physical activity, increase in screen time, decline in time outdoors, and decline in sleep quality compared to pre-COVID. Children and youth who attend school in person report better outcomes across all of the healthy movement behaviors compared to those who participate in school online or in a hybrid way. And there's not much difference between the online and the hybrid outcomes. Big difference in terms of if you attend school in person. Children and youth in Toronto report slightly worse outcomes across all of the healthy movement behaviors compared to those in the rest of Canada. And the final notable new finding from the fall data set is that children and youth who reside in apartments report significantly to moderately worse outcomes across some of these healthy movement behaviors compared to those who live in houses. So just as a final comment, pardon me, just wanted to reiterate what we've already heard today and in other forums, that the secondary impact of COVID-19 is unevenly distributed and correlates often strongly to social and built environment factors. Thank you very much, and I'm open to taking questions from the board. Thank you.
Thank you very much, Josh. Let me begin by opening it up. Are there members of the board who have questions for Mr. Fullen? Josh, I have one. As we're sitting in a moment where there are lots of conversations about enhanced measures that may be taken to contain the second wave, I recall in your first data set in the spring, one of the downstream impacts you looked at was household income and the different effect on racialized and non-racialized Torontonians. Do you have that data handy? Could you remind us of what that was?
Sure. Yes. So the impact of on household incomes lower than $50,000 of the pandemic condition was much more severe than above $50,000 annually, and the ability of those households to meet daily needs, so things like rent and groceries, was also proportionally higher on lower income households as well, and that is from the spring data set.
And so would it be fair to say, in terms of your analysis and recommendations for us from that data set, it would be if additional measures are required over and above where we are today, and perhaps even where we are today, that financial support recognizing that disproportionate impact must come alongside the public health restrictions?
Our data speaks to that conclusion, and it also speaks to the fact that families in vertical communities, so that data I just spoke to, need better access to public space and parks and playgrounds and things like that, so that they can have that they can maintain or increase their physical activity levels in the same way that kids who live in houses have been doing that throughout the various restrictions and lockdown periods.
And then just final question, Josh, is do you have a sense when this new, you mentioned that this is, you're referring to new data that you've received through your fall survey in Toronto and Canada. Can you tell us when it will be published? I know you've given us some pieces of it here.
Yes, so we are going to work very hard this week to publish something for November 20th, which is National Child Day, which will include more findings. I can't promise that it will include all the disaggregated data that you've seen from the first round of data, but at your next board meeting, I can certainly bring all of the disaggregated data to the board to see what the different impacts are on different kinds of families within Toronto and also across Canada.
Thank you very much, Josh. Okay, our next speaker and our final public speaker on this item is Derek Morin. Derek, do we have you on the line?
Yeah, can you guys hear me?
We can hear you loud and clear. Derek, you have been here before, so you'll have 3 minutes and you can begin when you're ready.
I just want to say, by me speaking at this meeting, this shall not be deemed to be in any way my consent expressed or implied, in doing so is fraud. God bless your Majesty the Queen, and long live her Majesty the Queen. And I object to the 3-minute time limit, as I would have liked to have listened to Julian Bayard for another 2 minutes. And let the record show, nowhere does it say that we can't ask questions at these meetings. So I provide a YouTube link for this in my written presentation. This is from MPP Randy Hillier in the legislature discussed this recent resurgence while exposing the rigged testing for COVID with PCR tests and high CT cycle threshold numbers, where he said, Dr. Yeadon, a former chief scientist with the pharmaceutical giant Pfizer, has stated, and I quote, most, if not all, of the PCR tests result in false positives due to high CT thresholds. Juliet Morrison, a virologist at the University of California, states, and I quote, any test with a cycle threshold above 35 is too sensitive. The Public Health Agency of Canada reported in May of this year that testing over 25 cycles provides dubious results. The prestigious Oxford professor Dr. Carl Hennigan has stated, a PCR test does not equal COVID-19. We know high false positive rates are due to high CTs, and Canadian and world experts agree. It should not be more than 25 cycles, yet according to the Journal of Virology, Ontario labs are testing samples at 38 to 45 cycles. Remember, it's not supposed to be over 25 cycles. Speaker, My question to the Premier, is your testing creating both a false understanding of the risk as well as false positives? And another question he had was, when did the Premier become aware of these faulty tests? Minister Christine Elliott responded, but I'm not quite sure what the member is suggesting. Are you suggesting we don't do any testing? We just stop testing? Is that the reaction we should be taking with this? What else would you suggest? So I just want to point out that she never did answer his question. She just skated around it. In my written presentation, I have a graphic and I provide the PDF from something from the Public Health of England describing PCR tests. They mention that PCR tests detect presence of viral genetic material in a sample, but is not able to distinguish whether infectious virus is present. Oh, that's interesting. So this is from Ontario Medical Officer of Health. I have the YouTube link provided. Dr. David Williams admits in the clip in my written presentation to Rob Ferguson from the Toronto Star, where he compares the first wave of COVID, the second wave, that compared to the first wave of COVID, the
Derek,
second wave
you're
is
just
now
at 3
less
minutes,
severe.
and I'd ask if you want to wrap up in a sentence, please.
Yeah, sure. Rob Ferguson asks, so is this why we're not seeing more measures right now because the severity is less? And Dr. David Williams simply said, right. So that's it.
Thank you very much, Derek. Are there any questions of Derek from members of the board? Okay, seeing none. So thank you to our 5 public speakers. We will now move this into committee for questions of our Toronto Public Health team. If you want to raise your hand to indicate if you have questions, and I will pull a little list here together. So questions for public health. Okay, I have Director Bowery followed by Councillor Perks. Director Bowery, when you're ready. And you'll have 5 minutes for questions.
Good morning, everybody. It's nice to see everybody this morning after a horrible storm this weekend. I do want to start by saying thank you to our Medical Officer of Health, Dr. Davila, and the whole team at TPH for your ongoing efforts with this resurgence and pretty alarming time for our city. I'm diverting a little bit away from the COVID stuff that we've talked about today, and I have a question regarding recommendation number 2, which focuses on the current flu vaccination strategy. So as many of you know, I'm a huge advocate of all vaccines and definitely a champion for our annual flu vaccine campaign. And this year, I have seen an unprecedented interest from the community to receive their flu shots. And that's largely driven by the media campaigns, messages from Toronto Public Health, us healthcare professionals. I've seen patients have been proactive. They've called pharmacies, they've booked appointments with their clinics, only to be told that there is a shortage of vaccines and their appointments are being cancelled. Yesterday, I participated in a flu clinic for my own family health team. And I spoke to someone who came in who's a community partner who's been involved in a door-to-door outreach vaccination strategy for seniors in the East End, as well as in Thorncliffe, which are all high-risk neighbourhoods. And their efforts have been thwarted by vaccine shortages as well. Similar story with the group at Baycrest, who have been doing senior outreach door-to-door work in the north end of the city. So my concern is when we have such roadblocks like vaccine, supply issues within our city with a very well, I think, publicized campaign for flu, our community lose faith in our vaccination campaigns. And I really worry about how these issues will undermine the COVID vaccine strategy when we roll it out in the future. So my question to the team is, and I recognize all the different levels, having done, large mass vaccination campaigns internationally, at the Toronto Public Health level, what can be done to address the current flu vaccine supply issues? And this might be a rhetorical question, but how can we acknowledge these issues and prepare the public for the potential roadblocks that we may face to ensure that there's an effective plan to roll out the COVID vaccine strategy when it is available next spring, hopefully next spring?
So thank you for the question, and through you, Mr. Chair, I'll just ask Dr. Finkelstein to be ready as well in case he has something further to add. But with respect to flu vaccine efforts here in Toronto, certainly for our own clinics at Toronto Public Health, recognizing that this was going to be a year with increased demand, we actually ordered additional vaccine for our own clinics, particularly because we provide vaccine to those who have and we focus our efforts on those who have challenges to access shelter populations, drop-in centers, et cetera. So we really went out of our way to make sure we had additional supply available, and as well for our public clinics. But as you know, vaccine supply and ordering is something that happens at the provincial level. We know that they were aware of the demand and increased demand. They were certainly preparing for that. My understanding is that they did order more vaccine, and I believe they are continuing to try to get more vaccine, and I believe Michael may have more information on that.
Yes, thank you, Eileen. Yes, last week I was speaking to our influenza lead, and you're right, our role here is to coordinate the vaccine orders and move them to the province and try to balance the needs of our community and to ensure high-risk individuals certainly have access to the vaccine is a very important part of the strategy. We do know that the province is searching the world for additional doses of vaccine, and they have been successful through the federal purchasing process. And so we are expecting additional doses of vaccine to arrive in the province. We're not sure exactly when, but we have heard last week that we are expecting additional supply. And so I guess the response there is to stay tuned. That those doses are being purchased, and so they hopefully will be here soon. I think from a standpoint of the second part of the question is that my response to having this great demand is that people need to be patient. Everybody cannot be vaccinated at once, and that will be a key part of our communications for the COVID-19 vaccine is that when it arrives, not everybody is going to be able to get it at once because we are expecting to have some issues around supply. The vaccine is going to be widely in demand, and we'll only have a certain number of doses, and leadership from the province and even the federal government will guide us on who those individuals will get the very first doses. And so there will be a time when the vaccinations for COVID-19 will begin, because as Dr. Villa indicated, we have seen 2 vaccines with certainly some efficaciousness, but not everybody will get it at once.
Director Barry, we're just over 6 minutes. Perhaps what I'll do is after we do a first round of questions, I'll see if there is a request for a second round to come back to, if that works. Okay. Next up, I have Councillor Perks, and can I just see by way of a show of hands, is there anybody else with questions following Councillor Perks? Okay, I will put myself on the list. We'll go Councillor Perks, then myself, and then we'll see if there's a request for a second round. Councillor Perks. Oh, and before you, Councillor, sorry, can I welcome visiting Councillor John Fillion, who has joined us here today. John is a longtime former chair of this board. And so thank you, Councillor Fillion, for joining us and for your counsel throughout this experience. Sorry, Councillor Perks, over to you.
Sure. Thank you very much, Mr. Chair. Dr. Davila, there has been considerable public interest in the decision-making process around public health measures at the province of Ontario. And I'm just trying to better understand it. So there is something called a public health measures table. They meet, provide advice to the chief medical officer of health for the province, and then he provides advice to the cabinet. Is that correct? Is that understanding correct?
So through the chair, you're right, the public health measures table provides advice to the CMOH. I presume, I can't confirm, that the CMOH then provides advice to the cabinet, premised at least in part on the advice from public health measures table.
Okay, that's helpful to understand. And the advice from the Chief Medical Officer of Health, we can't see what that advice is. That's confidential advice to government.
So through the chair, yeah, you're right. I do not know what advice the CMOH provides through to cabinet, and it's not publicly available.
Okay. Does Toronto Public Health have anybody at the public health measures table?
Yes, through the chair, we've had representation on the public health measures table since its inception.
And can you share with us what advice that public health measures table has given to the Chief Medical Officer of Health?
Through the chair, unfortunately, given the terms under which we participate on the table, we are required to keep the discussions and the advice that's provided at that table confidential.
So you can't tell us what advice is provided at that table?
Through the chair, I'm afraid I cannot.
Why not?
Through the chair, because we have been specifically asked to and signed on to confidentiality agreements that we are not to discuss outside of the table that which happens at the table or what advice is proffered.
So Toronto Public Health staff are only able to participate in generating advice on public health measures if we sign what, non-disclosure agreements?
So through the chair, it's not exclusive to Toronto Public Health. This is a condition for all members of the table.
So we can't see what medical and scientific advice is provided through the public health measures table because non-disclosure agreements are signed, and we can't see what advice the Chief Medical Officer of Health gives to cabinet.
So through the chair, to the first part of your question, that's correct. To the second part, I'm probably not the best person to speak to that, but certainly that's been our experience.
Thank you. That's quite alarming. Those are my questions, Mr. Chair.
Thank you, Councillor Perks. I'll just do a call before I go. Any other members of the board with questions? Councillor LongTerm, when you're ready. And then followed by Councillor Layton, I see.
Thank you very much, Chair. And through you to Dr. Davila, in your response to Councillor Perks about the individuals at these tables that are asked to sign and execute non-disclosure agreements, is that normal practice at the provincial government? Because I don't know if that's something that we do at the city, but I'd be curious to know if this is a normal procedure or is this something related to the pandemic?
So through the chair, I don't know if I can answer accurately as to whether it's normal practice or not, but I can say that it's not the first time I have seen this happen.
First time at the province or first time at these type of government information tables?
Sorry, to be clear, through the chair, not the first time that this has been asked of participants at provincial tables.
I see. And what would be the advantage or disadvantage of asking participants to sign this NDA?
So through the chair, again, I'm not sure that I'm the best person to speak to that, but presumably the issue is that there is a certain degree of confidentiality that's expected to be maintained by the organizer of the table.
Okay, thank you. Coming back to the presentation, if I can, the focus around the data around individuals who are racialized, who are low income, again, the message reinforced for us is that they are being disproportionately impacted. And some of those challenges have to do with living in poverty or some state of impoverishment. Do you think that enough financial supports have gone to those individuals and families to ensure that they can make it through to the other side of the pandemic?
So through the chair, my sense is that, the most accurate answer to the question would come from those individuals themselves. I think they're best positioned to speak to that. However, from what we can observe, from our seats in public health and from what we hear from community partners, particularly those who are on the ground and have closer relationships to those who are impacted most disproportionately, there continue to be significant challenges, a number of challenges around sufficient income supports, sick leave provisions, concerns around security of home and food, etc. So to my mind, there are more supports that would be beneficial, but the specifics of the supports, I think should be best be left to asking the individuals who are most directly impacted.
Thank you, Doctor.
Thank you.
Thank you very much, Councillor Wong-Tam. Next up, I have Councillor Layton.
Thank you very much. And Councillor Wong-Tam asked my first question about how common these non-disclosure agreements are, but maybe I can ask what the chronology was here for the province putting together the public health measures table. When was that table struck?
Through the chair, Councillor, I can't remember exactly. I'd have to go back and take a look. As I recall, it was in the sort of late spring, early summer at best, but I believe it was in the late spring.
And how often does that table meet?
So I would say that it has been, usually it's either once or twice a week. It has varied over the course of the pandemic.
In what form does the advice or recommendations out of that committee take? Is it a report? Is it like who holds the pen?
So through the chair, I have to think through how best to answer your question. The way it works is that there are other public health representatives from local public health, and they are asked to offer their best advice in respect of a number of issues related to public health measures in particular, and the response to COVID-19. So the discussion is held, questions are asked, there are opportunities for the members to comment on various public health measures, and from there advice is packaged up and provided to the Chief Medical Officer of Health. But I don't pretend to be deeply involved in all the details of how that actually happens.
Are you able to tell us what's the sort of secretariat who clerks these meetings? Who's taking notes?
So I think through the chair, it's reasonable for me to say that the table is called by the Ministry of Health and is supported therefore by ministry staff.
Okay, so ministry staff compile the advice from the table. Is like I suspect, and given what we all know now of how this advice takes shape, it's not voted on. It's a set of it's advice from various individuals.
Well, through the chair, I think that the notion is to try to come to some reasonable consensus to understand what local public health practitioners are witnessing on the ground. I think it's to inform that which the Chief Medical Officer of Health may need to put forward to provincial government, to the the government representatives there. I don't know that consensus is always possible, but where it is possible, clearly it is sought.
And are you able to say, generally speaking, the local medical officers of health giving their advice have reached a consensus?
Through the chair, I don't know that I can say that on every single account, but I would say that there is a fair amount of agreement that is expressed by local medical officers of health And you know, there will always be some areas of difference because we each have our own unique circumstances, but this is not exclusive to the public health measures table. Any table where we have the various local medical officers of health, you do see a great deal of consensus, not exclusive and you know, consensus across the board, but there is a fair amount of agreement on many of the key issues.
And my last question, none of the information you're discussing is proprietary or would reveal individuals' names, the advice that you're giving. I'm trying to understand why on earth none of this information would be public. Can you see any legal reason why there would need to be a confidentiality agreement?
So through the chair, Councillor, you know, I'm not sure that I'm the best source of legal advice, but you know, that might be a question better asked of our provincial counterparts. You know, I think I might just leave it at that. This is their table. We seek to participate in as you know, helpful and fruitful a way as is possible. We have had a number of different representatives partake at the table on behalf of us at Toronto Public Health. But I can say that we have all the way through tried to provide our best advice premised on our understanding of the evidence and as well our understanding of our unique circumstances here in Toronto, which are quite different and unique in the province as a whole.
Thank you.
Thank you very much, Councillor Layton.
Thank you.
Let me just check to see if there are members of the board who wish a second round. I would just note we're just after 11, and I've been advised by a number of citizen board members that they will have to leave at 1. And we do have another critical report in front of us, just as by way of a time check. But again, not to discourage anybody, just a time check. So are there any other members of the board with questions on this item? Okay, seeing none, I have a few very brief questions, Dr. Davila, based on the data in front of us and in the state of the second wave in our city and province, do you feel that further measures are required to reduce contacts and drop case counts at this time?
So briefly through you, Mr. Chair, yes, I do think we require additional measures and we are in active exploration of what those would look like and how best to implement.
And would it be your sense, looking to jurisdictions around the world, that additional measures would best be implemented if they were consistent across the region, the Greater Toronto Area, as opposed to different measures in different areas?
So through you, Mr. Chair, yes, particularly for areas that are, you know, immediately adjacent to us. I think I can see how it might be different for those further afield.
Okay. Now, when we talk about measures to reduce contacts and in turn case counts, the data has also shown that there are certain members of our community, both those who continue to work in frontline settings and those in marginalized communities who bear the brunt of many of those measures. Would it be your recommendation that additional enhancements and supports for those communities, frontline workers and marginalized communities, must go alongside any further restrictions?
So through you, Mr. Chair, yes, that's a standard of public health practice, that, you know, we want to make the healthy choices, the right choices, easier to do, and that includes provision of appropriate supports. And at the top of your list, if we were looking at those, in the past you have brought recommendations speaking to paid sick leave and income supports to support those to be able to isolate. Would those two recommendations still be on the top of your list, or are there others, specifically sick days and income supports? So briefly through you, Mr. Chair, yes, those would still be at the top. Most of the other protections are largely connected to financial security and that which comes along with it.
Okay. And then I suppose my final question is, assuming with additional measures and enhanced supports that we do indeed beat this second wave, as I have full confidence we will collectively be able to, what measures, what enhancements are required to sustain low, if not zero, case counts? In other words, how do we stop an endless cycle of reopenings followed by closures?
So through you, Mr. Chair, very, very briefly, I think that what's important is that we make sure that we implement public health measures to get case counts as low as possible. Certainly, we need to have strengthened public health systems in order to allow us to do that, which we can do to control spread from one case to the next. And then finally, not only for the purposes of better managing the pandemic and controlling its impact and mitigating its negative impact, but also on a go-forward basis from a health perspective, addressing health inequities and addressing the social determinants of health, better ensuring that there is equitable access to those things that actually create and maintain health across populations, and particularly those who've been most disproportionately impacted, would be key elements for preventing future activity in COVID-19. And the vaccine, of course.
So, and the vaccine, of course, but to your point, if we are to spike this second wave and maintain low and perhaps even zero cases, I heard you, stronger public health systems, test, trace, isolate, I assume, and then specific targeted measures to address health inequities. You spoke to income supports, sick days, and you've spoken to housing in the past. Would those be the two buckets, test, trace, isolate, and addressing health inequities?
Well, it's the combination of all the public health measures appropriately applied at the right time. So that speaks to the public health system, and then supports to ensure that social determinants of health are rightfully and appropriately addressed so as to mitigate and minimize health inequities.
Okay, thank you very much. Okay, members of the board, we're now going to bring this in for speakers. I'm going to put myself on the list to speak first, as I've spoken with many of you on a motion that I will move at the beginning. Other speakers, can I, by way of a show of hands, to build a speakers list here? I see Councillors LongTerm and Perks. Any others? Okay. Well, let me begin then first by moving the recommendations in the supplementary report. Those are the recommendations that we have from our medical officer of health in front of us. And let me also move 7 amendments, and with deep thanks to members of the board for their support on this. And I will review them briefly here before speaking more broadly. The first is that the Board of Health express its full support for our medical officer of health for continuing to use any and all powers in her authority and as she deemed necessary to tackle the second wave over and above the provincial framework. The second is for the Board of Health to call on the provincial government to immediately implement a fully transparent process of receiving public health advice, including making public the advice provided to the Chief Medical Officer of Health and the Ontario Cabinet by the various COVID advisory tables, including the public health measures tables. And then we have 4 additional amendments, very specifically here, calling on the provincial and federal governments to increase and accelerate the availability of the flu vaccine, for the provincial government to provide, as we have called for too long, sick days and income supports for those who need to isolate and cannot afford to do so, and for the provincial and federal governments to provide resources to support increased community outreach in our hard-hit neighborhoods, boots on the ground, support for those frontline community agencies that are working with affected community members to support isolation facility or to promote isolation facilities, support access to testing, as well as access to other wraparound health and social supports. It's been a long 10 months, and we have a long way to go. And I do not, as we've done consistently, I don't want a meeting to pass without thanking and commending our Toronto Public Health team. 2,000 members strong and growing for their tireless work, their dedicated work, their compassionate work, and to our medical officer of health for her leadership in stewarding that entire team. And I also want to recognize and commend our medical officer of health and the team for continuing to recommend and, where necessary, take, under her own authority, additional steps to protect the health and well-being of our residents. And to our residents, everybody in our city has sacrificed over the past 10 months, some far more than others, to the family members of those who have lost lives, into the individuals, far too many marginalized communities who bore the brunt of inequality before COVID and in turn have borne the brunt of COVID today. We want to thank them and acknowledge their sacrifice. So where are we today? Our objective today is the same as it has always been: to save lives, to protect the capacity of the healthcare sector, and to minimize the social, health, and economic effects associated with measures. That's our overarching objective. It has been consistently throughout, and it is today. But where are we in terms of our next steps and our objective right now, today, in the second wave? I think very clearly it needs to be said, our collective objective is to beat this second wave by driving down case counts, and you do that by driving down contact, and to keep it down. Our objective is not simply a cyclical scenario of reopenings followed by closures, but rather to have as few, if not zero, COVID cases in our city. That's the objective. And so in doing so, the objective is not simply to beat the second wave, but it is to ensure that the necessary systems that our medical officer of health has spoken to are in place not only to prevent a third wave, but to beat this virus. You cannot live with COVID without beating COVID, and you beat it by targeting zero cases. So what does it mean to beat COVID right now and prevent a third wave? It's not a waiting game just for a vaccine, though that's critical. It is today in the move towards enhanced measures, and I know our medical officer of health has spoken to that active work underway. It's the move to those enhanced supports alongside restrictions for frontline workers, for communities to access testing and isolation facilities, the necessary employment support and sick leave provisions to ensure that those who can't work from home are able to isolate, and also to ensure that they have the necessary frontline protections for when they're working. And it's rigorous test, trace, and isolate systems. We can do this. Other jurisdictions have shown us the way. This doesn't have to be a false choice between the health and the economy. You financially support those people and businesses who are being affected in order to protect us all. That is the common good. Now, does this work require public trust and confidence in government's response? It does. We're asking a tremendous amount of our residents. But we can't expect our residents to follow our difficult advice if we're not being transparent in providing them with information to that advice. And it's to that extent that the current process of a confidential provincial public health measures table that provides confidential advice to the Chief Medical Officer of Health, who provides confidential advice to Cabinet, who in turn makes decisions in private, that is a recipe for a lack of trust. It's also a recipe for bad decision-making. Full and complete transparency is now the order of the day. And so I'll simply close by saying that in this moment of unbelievable destabilization and pain and sacrifice, our task today is, as it ever was, to continue to protect the health and well-being of our residents. And we do that not only by following the data, but by having at all times a central and embedded focus on equity. Because unless we protect the health of all, we will never beat COVID. Thank you very much. I'll now open up the floor. I have next Councillor LongTerm. Councillor LongTerm, when you're ready.
Yes, thank you very much, Chair, and thank you for tabling that motion, and also for taking the time to canvass the Board of Health members in advance. I certainly appreciate that type of leadership. of bringing everyone in. And I think that actually speaks to the point of what's not happening at the province, is that we're not seeing that level of openness, and certainly the lack of transparency is of concern. But I think also what it's doing is it's creating confusion and distrust in the public. And these are difficult times. I don't think any of us will be able to deny this. And quite honestly, none of us have lived through this before. So in order for us to get in front of it, we're going to have to be as open and transparent and share as collaboratively as possible so we can make the best decisions. Out of the chair's motion, I wanted to highlight one piece, and that's recommendation number 4. Recommendation number 4 is asking the province to accelerate the distribution, to expand the reach of financial supports that are going to vulnerable communities that have been disproportionately impacted by COVID-19, and in particular women, people living with this, racialized individuals, and so forth. And we have, I think, now heard from our staff once again around the fact that this pandemic and this virus has not affected all of us equally. And there are many people who are continuing to fall through the cracks. And it is entirely frightening if they're not able to make ends meet, pay their rent because they don't have supports of a COVID eviction moratorium in place. The fact that they are working in those essential work and not getting pandemic pay to help them make the requirements to keep food on the table, to keep their children in school, not having adequate childcare, and a whole host of other supports that must be in place in order for people to make it to the other side, we know is going to be devastating. 97% of all Ontarians that are receiving financial supports right now are getting that directly from Ottawa. 97%. That means that the province is only chipping in a meager 3% of financial supports. And yet we found out recently that they're sitting on $9.3 billion of unallocated, unspent money. All the while, families are struggling to make ends meet, to pay their rent, to pay their mortgages, to put food on the table. I cannot understand how it is that the provincial government has failed so spectacularly when it comes to providing financial supports for Ontarians in need. And I'm hoping that we can accelerate that call, amplify the call to get them to spend smartly and more directly into people's accounts so that they can in turn take care of themselves and their families. And thank you, Chair, for the opportunity.
Thank you, Councillor Wong-Tam. Next up, I have Councillor Perks, and then can I just see by way of a show of hands, are there additional speakers after Councillor Perks? Okay, seeing none, Councillor Perks, you have the final word.
Thank you, Mr. Chair. I'm profoundly alarmed. We are asking everyone in our society to endure hardships. We're asking them to stay home. We're asking them to stay away from family and friends. We're telling some people that they've lost their livelihoods. We're also experiencing deep inequities in the impacts of the COVID-19 pandemic. And yet we discover here today that for no reason that I can think of, expert public health advice is being kept secret. The decision-making process at the province of Ontario is being kept secret. I can't know, as a decision maker, an elected official in the City of Toronto, a member of this Board of Health, I can't know what the experts are telling the Chief Medical Officer of Health. I can't know what the Chief Medical Officer of Health is telling the Provincial Cabinet, and I can't know what evidence or information or lobbying or other input is being considered by the Provincial Cabinet when they're deciding what the rules will be for dealing with COVID. We are being asked, each of us, to participate, to do our best, to help, and we're doing it in an environment of secrecy. You cannot ask members of a society to pull together, to join together, to work together, to contribute together, if the provincial government is isolating itself from that effort by hiding behind a veil of secrecy. What evidence, what sits on the scales in the decision making? Who's talking to the cabinet ministers? Why are they making the decisions they're making? How is it that Torontonians and Ontarians can't know what's going on in the management of the most important thing any of us will ever deal with in our lives? It's shocking. I'm speechless that this is the process. Thank you for moving motions to ask the provincial government to make the process transparent. Thank you also to the frontline staff who are working on all of this. But for heaven's sakes, we need, if we're going to ask Torontonians and Ontarians to contribute, they need to be able to see why they're being asked to take certain measures and what it is they're contributing to. Thank you.
Thank you very much, Councillor Perks. Councillor Perks was the final speaker. Just a final call for speakers. Okay, seeing none, we'll start by voting on the amendment that was put in front of us, and then we'll move to the supplementary report and staff recommendations. So the amendment is here. All those in favor, if I could see by way of a show of hands. Any opposed? Seeing none, that carries unanimously. The staff recommendations from our Medical Officer of Health contained in the supplementary report. All those in favor, by way of a show of hands. Any opposed? Seeing none. Or Councillor Layton, is your hand still? Nope, your hand is down. Okay, seeing none, that carries unanimously. Thank you very much. We will now move to item HL 23.2, opioid poisoning crisis in Toronto. We will begin. We have a brief presentation from Nicole Greenspan on behalf of Toronto Public Health. We then have 17 speakers who we will go to hear from before moving it into committee. Nicole, welcome to the board. Thank you for being here. When you're ready, please take us through.
Thank you. Good morning. My name is Nicole Greenspan, and I'm a Policy Development Officer with the Toronto Drug Strategy Secretariat at Toronto Public Health. The staff report before you responds to a request made by the Board of Health at its September meeting for the Medical Officer of Health to provide an update on the status of the opioid poisoning crisis, the focus of Toronto Public Health's response, and further actions needed to address the crisis. In this presentation, which is brief, I will provide a brief summary of that report and key recommendations in it. Can you move to the next slide? So I would like to start by providing an overview of what the opioid poisoning crisis has looked like in Toronto, and you can see data up until 2019. And while I'll be focusing on numbers, we of course need to remember that each number represents an individual person who may have been someone's colleague, family member, or a loved one. And sadly, we have seen an alarming rise in the number of deaths, particularly since 2017, and a high number of people dying from opioid poisonings. So over the past 3 years, and 293 deaths last year alone. This trend has been happening across the province as well. Please go to the next slide. There's a lot of concern about the impact that COVID-19 is having on the opioid crisis, on the opioid poisoning crisis. So what you can see from this graph is that between April and June 2020, so this is the second quarter of 2020, 113 opioid overdose deaths occurred in Toronto. This is the highest recorded since the third quarter of 2017. When we compare this to what we have seen to the average number of deaths from the same period over the past 2 years, we're seeing a 53% increase. It's not shown in this slide, but recent data in a report that included the coroner is showing that this trend is present in Ontario as well. Can you please move to the next slide? On my screen, it's in portrait mode and it should be in landscape mode. But what this is a graph of suspected opioid overdoses, and fatalities attended by paramedics. And we have also been noting concerning trends in the data about suspected opioid overdoses by Toronto paramedic services. And this is about, the concerning trends are particularly about fatal calls that have occurred during COVID-19. So what this graph shows is that there are the monthly number of suspected opioid overdose calls attended by paramedics, the blue line in this graph. They fluctuate, and there has been some periodic surges, including this year. What is difficult to see, and this is the gold line of the graph, is that the number of suspected fatal opioid overdose calls attended by paramedics has been noticeably higher than in previous years. So it's noticeable in two ways. First, the average number of fatal overdose calls attended by paramedics has increased. In 2019, the average was 12 per month. But in the first 10 months of 2020, it has risen to 21 fatal calls per month. The second way it's noticeable is in the total number of fatal overdose calls, which have noticeably increased. During the course of 2019, paramedics attended 141 fatal calls. In the first 10 months of 2020, they have attended 206 fatal calls. We are seeing more deaths in 10 months than for all of 2019. And while this data is concerning on its own, it's important to note that paramedic data doesn't capture all opioid-related overdose deaths in Toronto. Coroner's data shows, on average, double the number of deaths that are seen in the paramedic data. Can you please switch to the next slide? If you could also rotate that, thank you. So I'm going to draw your attention to what else we know about COVID-19, about how COVID-19 has adversely impacted the opioid poisoning crisis and people who use drugs. While the full impacts are not yet known, anecdotally and initial reports show that there is a decrease in the availability of harm reduction treatment and treatment services, shelter, outreach, and other related services. People who use drugs are reporting an increased fear of criminalization due to increased police street presence. There is a change in the availability of drugs, and drug checking services have detected unexpected substances of concern in the illicit supply. And the need for safer supply options are more urgent. We've also heard some reports of concern about exposure to COVID-19 when people who use drugs interact with drug suppliers, in particular, people who use drugs who are immunocompromised. Next slide, please. So Toronto Public Health has remained focused on implementing the Toronto Overdose Action Plan and working with community partners to help address emerging issues related to the opioid poisoning crisis that have come along with the COVID-19 pandemic. Our advocacy efforts are focused on advancing key policy actions, including decriminalization of the possession of drugs for personal use and support to fund and deliver safer supply programs. We continue to monitor the opioid crisis and share new data and information as soon as possible. This has included issuing a number of drug alerts during the pandemic. On the slide, it mentions 11, but we issued a 12th one last week as well. These alerts identify increases in suspected opioid overdose deaths, as well as when potent contaminants detected in Toronto's unregulated drug supply are detected. The Works at Toronto Public Health continues to deliver a range of harm reduction services, including supervised consumption services. They also provide support to harm reduction programs and other city divisions on safe and effective delivery of their services during the pandemic. However, it is important to note that some services are operating at a reduced capacity due to public health measures required during the pandemic. An example of how the Works has pivoted during the pandemic, they recently created an online version of their overdose recognition and response training. This is facilitating access to this training and has broadened its reach. Next slide, please. There are a number of recommendations before you today for consideration. And on these next few slides, I'm going to highlight some of the key actions, the first of which are directed at the Federal Minister of Health. Our staff report highlights the growing number of officials and groups calling for decriminalization, including the Canadian Association of Chiefs of Police. More and more, people understand that we need to treat drug use as a public health issue. As you may recall, in June, the Board of Health called on the Federal Minister of Health to permit the simple possession of all drugs for personal use. The need for decriminalization has become more critical as the opioid poisoning crisis continues to worsen during the pandemic. And so we are recommending that the board reiterate its support for this action. Another key action needed now is the expansion of safer supply programs. We have a few safer supply programs operating in Toronto, but they need long-term funding, and we need to expand the types of safer supply programs available to include, for example, injectable medications and options for people who use stimulants. Again, the board has supported safer supply in the past, and as the opioid crisis escalates, the need for these initiatives has intensified. Next slide, please. These are some highlights of the recommendations directed to the Provincial Minister of Health. We are again recommending the board urge the province to convene an opioid task force to oversee action across Ontario. The province also has an important role to play in supporting and funding safer supply programs, including putting the necessary medications on the Ontario Drug Benefit Formulary. This remains a key ask of the province, and we're hoping the board will support it again. We are recommending that the province create an urgent public health needs site program. So these sites are also known as overdose prevention sites, as more of these life-saving services are urgently needed. The federal government has set the policy foundation for this, and we need the province to act. We also need an expansion of the program options for supervised consumption services. So these would include things such as peer witnessing and virtual services. Next slide, please. Further recommendations directed to the Provincial Minister of Health include the need for some of the recently announced funding for mental health and addictions to come to Toronto for evidence-based, on-demand treatment services. The report also recommends that the province designate harm reduction and treatment services as essential services, and to provide funding to ensure these services can effectively operate and meet the needs of people who use drugs during the COVID-19 pandemic. In addition, the need for grief and trauma supports is more urgent than ever. The impact of the rising number of people dying from opioid poisonings is continuing to have a devastating impact on their friends, families, and the people who work with them. Currently, there are very few supports available. Next slide, please. The last recommendation I will highlight recommends that the Medical Officer of Health work with the Executive Director of Social Development, Finance and Administration to include the decriminalization of the simple possession of all drugs for personal use as a key plank in the city's community safety and well-being plan. This is in recognition of the differential and negative impacts that the criminal law has on equity-seeking groups in Toronto, such as Black and Indigenous peoples. So finally, I want to say that clearly, this is the final slide, if you could go to the last slide. Clearly, the opioid poisoning crisis in Toronto has been adversely impacted by the COVID-19 pandemic, and these recommendations reflect key actions that are urgently needed. It's the end of my presentation, but I would be happy to answer any questions. Thank you.
Thank you very much, Nicole. And I believe that was your first time presenting to us at the board, so thank you very much for all your work. We're now going to go to hear from our public speakers. We have 17 registered speakers on this item. Welcome all. You'll each have 3 minutes, followed by questions from the board. And I will read out the next 3 speakers so you can be aware. We're going to start with Sandra Kaho-Chu, followed by Julian Kola, followed by Angela Robertson. So we will begin Sandra Kahan-Chu from the HIV Legal Network. Sandra, do we have you on the line? Oh, Sandra, we need you to connect your audio, please, in order to address the board. Do we have you yet? Hi, Sandra, can you hear me?
My apologies. Yes, I can. Thank you.
Wonderful. Sandra,
So
thank you for joining. You'll have 3 minutes when you're ready. Really appreciate it.
Great, thank you, Chair. And thank you for the opportunity to make a deputation today. I am with the HIV Legal Network, and we just released a report called Making the Ask, Minimizing the Harm that was shared with the Board of Health last week. I hope you all had an opportunity to skim it. I'm not going to repeat a lot of the findings in the Medical Officers of Health's report, but I wanted to focus my deputation today on the recommendation to seek a federal exemption from the Health Minister to decriminalize simple drug possession via a Section 56 exemption. And I know this Board of Health has made that recommendation before, including most recently in June. What I'm hoping to press the Board of Health today to recommend is to actually go further. We fully support the recommendation for a nationwide decriminalization, but this is likely a longer term prospect that will take time and ongoing advocacy to eventually materialize. In the meantime, people in Toronto continue to face the threat of arrest and the harms of criminalization persist. In 2018 alone, we note that there were 6,712 arrests that were made for drug offenses. And as Nicole earlier mentioned, the brunt of these arrests fall disproportionately on racialized Black and Indigenous communities. As Canada's Chief Public Health Officer stated succinctly in August 2020, you cannot arrest your way out of an opioid crisis. So therefore, in the interim, we urge the Board of Health to communicate directly to the Federal Health Minister and to also request a Section 56 exemption that applies to the City of Toronto. There's no restriction in the Controlled Drugs and Substances Act as to who may request or be issued an exemption. Section 56 merely says that the minister may exempt any person or class of persons and set any terms and conditions that the minister considers necessary. As you know, in Ontario, every Board of Health has a responsibility for health promotion, health protection, and disease and injury prevention. Local medical officers of health also have broad powers and obligations to protect public health within their jurisdictions. So on behalf of a municipality, authorities such as a Board of Health or a local medical health officer could request a federal exemption to protect people within its jurisdiction from criminal prosecution for simple drug possession. So requesting a local Section 56 exemption from the Federal Health Minister is entirely in keeping with the Toronto Board of Health's role and responsibility. A nationwide exemption is, of course, ideal, but the City of Toronto can move more quickly to reject criminalization within its borders. Now more than ever, this policy change will save lives and promote public health, as well as save public funds, and it will be an opportunity for Toronto to also adopt a bold and meaningful response to the drug poisoning crisis that has swept our city. Thank you. That's the extent of my comments today.
Thank you very much, Sandra. I'm just going to caucus the board. Are there members of the board with questions for Sandra? Okay, seeing none. Thank you very much, Sandra. Next, we have Julian from the Canadian Institute for Substance Use Research, University of Victoria, who will be followed by Angela Robertson and then Jason Altenberg. Julian, do we have you on the line?
Yes, I'm here. Thank you.
Welcome, Julian. Thank you for being here.
Thank you for having me. So as you mentioned, I'm a postdoctoral research fellow at the Canadian Institute for Substance Use Research at the University of Victoria and also at the Centre for Drug Policy Evaluation at St. Michael's Hospital. I live and do the majority of my research here in Toronto. As a public health and drug policy researcher, I read with interest the recommendations from the Medical Officer of Health on the overdose crisis, and I support them completely. But I'm here today to tell you that these recommendations do not go far enough. We're facing an absolute crisis of overdose deaths in Toronto, particularly among people experiencing homelessness and using the shelter, respite, and physical distancing hotel system. I'm going to speak today to one thing that the City of Toronto can do immediately to save lives. Quite simply, the city needs to immediately open overdose prevention sites within these sheltering settings across the city and enhance on-site harm reduction services available. I won't go through the evidence on how overdose prevention and supervised consumption sites save lives, as this group has seen this evidence multiple times. But I will note that in the midst of a devastating overdose crisis for years now, the response to the overdose crisis within the city's sheltering system has unfortunately lagged behind. Despite the challenges that COVID has introduced, it's necessary for the city to move ahead on this issue immediately. Newly released data demonstrates that COVID has worsened the overdose crisis in Ontario. Just last week, an absolutely devastating report was released using data from the Chief Coroner's Office of Ontario. It examines overdose deaths during the first 4 months of COVID and shows a 38% increase in overdose deaths above pre-COVID levels. This report also shows an increase in deaths in hotels, in shelters and respites, and outdoors since the pandemic began. The most shocking part of this report is that it also predicts that Ontario will see almost 2,300 deaths from overdose in 2020. Now, just to contextualize this, Ontario saw 1,500 deaths in 2019 when it became the province with the highest number of overdose deaths in Canada. I'm having trouble comprehending 2,300 deaths in Ontario in 1 year because I thought last year was bad. Now, the silence from the provincial government, from our Premier, from the Minister of Health is notable. They've not mentioned this report. There have been no announcements of emergency funding, no condolences to families. They have not talked about the enormous loss and collective trauma that these numbers represent for families and communities across Ontario. All of our indications are that the situation on the front lines is getting worse. As Nicole mentioned, we learned that October was the deadliest month for overdose deaths ever recorded in Toronto. Now, there are models that we can draw on to help us respond to the dual crises of COVID and overdose. In the early days of the pandemic in April, I was part of a team in Toronto that quickly led a consultation on how to provide a COVID and isolation and recovery site for people experiencing homelessness and diagnosed with COVID. One strength of this model was that it included integration of community health teams on site, of harm reduction workers, peer teams, overdose prevention sites, managed alcohol programs, and safer supply. I'd like to contrast this to the situation in shelters and respites, where despite 4 years of an overdose crisis, we still don't have a single overdose prevention site open in shelters or respite settings in Toronto. People have been dying for years now of overdoses in shelter bathrooms, and we've traumatized an entire generation of frontline workers by leaving them to repeatedly pull people who are blue and not breathing out of toilets to try desperately to revive them.
And Julian, I don't mean to shorten your comments in any way, just to let you know you're over 3 minutes. If you could seek to wrap up in a few sentences.
Thank you very much. So last week, Dr. Davila, the city breathed a sigh of relief when you decided to move forward ahead of the province to put in place measures to protect the safety of the people of Toronto from COVID. I call on you to do the same right now within our shelter system and to open overdose prevention sites across the city to save people's lives this winter who are staying within the shelters, respites, and physical distancing hotels. Thank you very much.
Thank you very much, Julian. Let me open it up to members of the board. Are there any questions for Julian? Okay, seeing none, thank you. Our next speaker will be Angela Robertson, again followed by Jason Altenberg, and then Juno Zavitz. Angela, welcome.
Thank you. Can you hear me?
Angela, we can always hear you loud and clear.
Thank you. So my name is Angela Robertson, and I'm the Executive Director of Parkdale Queen West Community Health Centre, one of the health centres here in the city, embedded in providing harm reduction services, and as well one of the community partners providing services at the COVID recovery site for folks who are homeless and unsheltered. Given my 3 minutes now from 5, I will just go over the other pieces that I think Julian and Nicole has amplified, and really begin by saying this moment calls for immediate action and implementation of strategies that will change the trajectory that the Chief Coroner identified in his report and that Julian and Nicole just spoke to. And that this is not a moment, I think, for more dialogue, for intergovernmental game playing of the hot potato passing, that this is a moment for, I believe, Toronto Public Health and the Board of Health to declare a public health overdose emergency and to resource that call accordingly. Julian identified the number of deaths that we have seen and that is projected. When there was 1,200 deaths in 2017, this board and public health leadership in 2018 was bold in the face of provincial government slippers, dragging and denial of a crisis. This Toronto Medical Officer of Health, Dr. Eileen Davila, described the public health emergency of opiate overdose-related deaths as the defining health crisis of our time. This bold leadership spoke out in support of supervised consumption services when the provincial government placed a pause on funding previously approved services and withdrew services for overdose prevention services. This leadership then affirmed the research and scientific evidence that harm reduction interventions saves lives and must be resources responded to the opiate crisis, and as doing so as a public health emergency that it is. We are in a pandemic, and Toronto's public health leadership, in the face of provincial government mixed messages, as Julian spoke to, have stepped forward in dealing with the science, in calling for activities and strategies to reduce COVID spread, deaths, and to keep us safe. We must use that same strident call now to prevent preventable opiate deaths in this moment. Parkdale Queen West Center and our work at the recovery site, as Julian identified, saw it important to embed with our partners, ECHA, TNG, UHN, SSHA, to embed harm reduction strategies at the COVID recovery site because we see it as important. So at that site, as Julian noted, we have overdose prevention services, peer witnessing, safer opiate supply management, alcohol program, and safer supply distribution. The board needs to demand and enable all services to take this approach or partner with others to bring that support. I see my 3 minutes. I would say that the overdose public health emergency that we are in has had differential impact on Black and Indigenous populations, and that I would suggest to you that we are seeing a differentially higher death rates among those populations, and that the war on drugs has meant further criminalizing and stigmatizing of those individuals and those communities. I would suggest to you that we need to take the policing out of overdose response, that we need a community-based harm reduction strategy. It is not okay for a police officer responding to an overdose death in a supervised consumption service to ask the client and service providers if the individual was attempting suicide. This is not appropriate. Lastly, I would suggest to you that a few months ago, the city made a political decision and found $50 million over 10 years to invest in body cameras for Toronto's police services in the face of evidence that cameras do not reduce instances of police violence. In the face of this decision, we cannot hear you say that you do not have the money to invest in these evidence-informed, life-saving harm reduction strategies to address this public health overdose crisis. Thank you.
Thank you, Angela. Angela, I have one question. The model of embedding harm reduction supports within the shelter, the homelessness recovery and isolation sites, that was a model I know that your organization is helping to is operating. Was that developed in partnership with SSHA and TPH?
That was developed in partnership with all of the providers at the site. So that's SSHA, the UHN, ECHA, and the neighborhood group TNG.
So that model involved with all the partners, community organizations, the healthcare sector, and city providers, is that a model that you believe could effectively be replicated throughout our shelter support and housing system?
Yes, I believe it is a model that can be replicated, and I know that currently there are efforts being advanced by SSHA to bring and embed more harm reduction services through community collaboration and community partnerships to some of the physical distancing sites. I would say that additionally what is needed, however, is some leaning in on the province to have them activate their ability to lift up overdose prevention services so they can use their class exemption to expedite the lifting up of OPSs in these physical distancing sites.
Okay, thank you very much. I have a question from Councillor Perks.
Thank you, Mr. Chair, and thank you, Angela, for both the work you do and the advice you give us. I just want to make sure I understood clearly that the piece around harm reduction services and overdose prevention work in our shelters. So currently you're consulting on a conversation or have consulted on a conversation about those measures the city can take, but in addition, you're advocating that I think you said lean in, and maybe you meant lean on the province to give us the exemptions so that we can provide the full suite of services. Have I got that right?
Yes, we are currently in a collaboration with SSHA, where community partners have been resourced to bring additional harm reduction services to some of the priority physical distancing sites where there have been high instances of overdose and deaths. So we are currently working on that strategy and implementing that strategy, but concurrently, it would be important to lean in, lean on the province to utilize a mechanism that they have, but they have refused to activate, because if they activate it, then it would have them be forced to rescind their withdrawal of funding for the existing OPSs that were previously funded.
Thank you very much.
Thank you.
Okay. Thank you very much, Angela. Our next speaker is Jason Altenberg from the South Riverdale Community Health Center, followed by Juno Zavitz, followed by Melody Alterton Ballack from Street Health. Jason, do we have you on the line?
You do. Can you hear me, Mr. Chair?
Like Angela, we can always hear you.
There we go. Thank you for the opportunity to give the deputation. I want to begin by voicing my strong support to the recommendations that are before you this morning and commend Dr. DeVilla and the Drug Strategy Secretariat. These are vitally important recommendations to help us address this drug poisoning crisis. In the past 6 months, the staff teams at our 2 consumption services at South Riverdale and Moss Park responded to over 400 overdoses, and we've seen an increase in demand for our core harm reduction services across the southeast of the city. This is an exponential increase from the same time the year before. Through the pandemic, we've also been able to lift up safer opioid supply programming funded by the feds until March, as well as COVID testing and many other programs. We joined the Board of Health in appealing to the federal government for decriminalization and echo the need for the city to look at policies that will mirror decriminalization in the absence of federal action. I'd like to use the rest of my time to talk about some specific details that I would like to see flush out some of these recommendations. With respect to decriminalization, it's essential to further remove and minimize police from our overdose responses. Police officers who do encounter overdose or are asked to attend must universally stop using these incidents as opportunities to criminalize people on the scene. We do require the reinstatement of the moratorium on residential evictions, as the threat of eviction is contributing to the lack of safety of people who use drugs and the risk that people will delay calling for help or not call for help at all. Our staff and community members continue to witness anti-Indigenous and anti-Black racism in the work of emergency services and landlords in the treatment of people who use drugs, and systemic reforms must be a first priority if we are going to see a change. Regarding the request for ongoing federal and provincial funding for our safer opioid supply programs, we couldn't agree more that these programs need something other than short-term federal grants, and funding for drug user health services to community health partners like the CHCs should be global in nature and allow for a continuum of outreach, harm reduction, overdose prevention, inclusive of supervised consumption and safer supply and treatment. We need an end to inflexible and piecemeal funding of these services. The current lack of stable funding and a high degree of local variability in these services is contributing to the overdose crisis. Regarding injectable formulations and safer supply, while we do need injectable formulations covered by the Drug Benefits Program as recommended, we must act now with available resources to provide safer supply. We have seen that safer supply programs can be offered successfully with prescription opioids currently available on the ODB formulary. And while we continue to advocate for the addition of injectable formulations, we must also actively support the scale and spread of low barrier safer supply options that can be offered to people who use drugs today. IOT programs are necessary, but where they exist in Canada, they are not offered as the first line option for care or treatment. A harm reduction-based safer supply framework is necessary. And given the toxicity of the unregulated supply, you heard about the burden on the community health centers currently offering safer supply requires the support of public health and other health partners. I strongly encourage TPH to further partner with us to scale up the provision of safer supply options within TPH programs and to help us advocate for the inclusion of these in hospital-based programs like rapid access addiction medicine and rapid access clinics. The abandonment of the Provincial Overdose Task Force by the Minister of Health and the Chief Medical Officer of Health provincially that was co-chaired by my predecessor is a shameful abdication of responsibility, a political and public health failure in leadership. If the province does not reconvene, I'll finish here, I would suggest that the renewal of such a table, the community would be willing to work with leadership like the Medical Officer of Health of Toronto and others across the province to reconvene and lead a provincial task force without that leadership. And I know I'm over, and so I will stop there.
Jason, thank you very much. Let me now open it up to members of the board. Are there any questions for Jason Altenberg? Okay, seeing none. Thank you, Jason.
Thank you.
Next up, I have Juno Zavitz from Breakaway Addiction Services, followed by Melody Alterton Ballack, and then Kesla Forsyth. Juno, do we have you on the line?
Hi, yes, can you hear me?
We can hear you. Juno, when you're ready.
Thank you. Good morning, members of the board. I'd first like to start by saying thank you for the opportunity to give a deputation today. My name is Juno Zavitz. My pronouns are they, them. I'm coming to you today in representation of Breakaway, which is a harm reduction-based substance use support agency in Parkdale. Some of you may be familiar with us. I am Breakaway's lead on grief and loss work within the opioid crisis. So that's what I'm here to speak about today, which is the urgent need for grief support in the middle of this opioid crisis, which we know has been direly exacerbated by COVID-19. I'm coming to you today not just as a harm reduction worker, but as someone who has additionally worked in the nonprofit bereavement sector in Toronto. Traditional grief and loss supports in Toronto do not work from the harm reduction frameworks we champion and are not equipped with the expertise found within the harm reduction sector. During this crisis, there has never existed free and accessible supports for deaths resulting from substance use, and more importantly, harm reduction informed grief support for those people who are actively using drugs in grief processes. We're living in a fourfold crisis: the opioid crisis, the housing crisis, COVID-19, and as well an epidemic of traumatic grief. Grief support has been provided on an ad hoc basis every day by workers, peers, community members, and those providing support have very few places to turn that don't judge and shame drug use, especially in periods of grief. Much like the lag in years it took to instate safe consumption sites, we are years and years behind in addressing the epidemic of traumatic grief our communities are living with. It is well overdue that there exists a strategy to relieve this pressure from frontline workers at safe consumption sites, addiction support agencies, and shelters, and address the mass trauma that has been placed in the laps of people who have lost partners, children, friends, and co-workers to overdose and substance-related deaths. In my role, I regularly talk with managers and frontline workers who have had funding for these types of programs turned down. Frontline workers are then left scrambling to support their clients while also attending to their own grief and that of their coworkers. In my personal life, in community as a peer, I regularly receive requests for local and accessible resources following overdose deaths that are non-stigmatizing and harm reduction informed that I can send my friends and peers to, and I have nowhere to send them. Breakaway and other agencies are well positioned to provide this support, and during COVID-19, we have written 2 funding proposals for a grief support program. One was turned down by a ministry, and if we are successful in the second, which is Toronto Urban Health Fund funding, it does not start until next summer. Even then, it only covers enough for a needs assessment and does not include direct services for service users and frontline workers. This is the stalemate we are currently faced with from funders and social services. We are continuously told we must provide more evidence that there is a link between the grief of overdose deaths and increased rates of substance use, as if the number of deaths and increasing overdose rates are not evidence enough. This has massively delayed our ability to provide direct services and will continue to do so as deaths occur at exponential rates during COVID-19 and the grief continues to compound.
Juno, we're just over 3 minutes. If I'd ask you to summarize,
I'll wrap
please.
up. What we are dreaming of is a program hub and sector-wide network that includes immediate support following a death within our sector, as well as support groups, individual counseling, funding for memorial events, and trainings for other workers in bereavement agencies. So my ask today is for this board to endorse that there is a fourth epidemic that we are living with, which is traumatic grief, and to trust what we know to be true in our sector. Grief begets increased overdoses and therefore additional grief. So I want to thank you for your time today.
Juno, thank you so much for being with us here today and your work. Let me now open it up to members of the board. Councillor LongTerm has a question for you.
Yes, thank you very much, Juno, for your deputation. I want to understand the requests a little bit further. So a number of the things that we need, Nicole at the beginning of her presentation has cited that we have to get support and permissions from the federal and provincial government. One of them was also grief and trauma support, but in your citing today, and specifically in your presentation, is it your belief that the City of Toronto can also step in to provide that grief and trauma supports in the interim of the provincial government funding such services?
Yeah, thank you, Councillor, for your question. A number of years ago, I sat on a oversight panel, which included a City of Toronto team that would send out workers in the events of shootings, stabbings, and swarmings. I can't remember the name of that team. I know it is still active. One of the requests that I hear from frontline workers in the needs assessment I have started to do is the request for some kind of network, ideally from the city, that can be activated when there are overdoses on site. Because what is happening right now is that there is no immediate response available. I don't know whether that would come from the city, but part of the ask is to really, I know this was part of the recommendation today, but we didn't spend a lot of time talking about what it means to address the traumatic grief. I know that we are really caught up in preventing further overdoses, but I want to speak to the other epidemic that we are really living with.
Thank you. And you cited in your presentation that you have an application in for a grant from the Urban Health Fund. Is that correct?
We do, from TUF, yeah.
And it's for a program that, if you are successful, will be for a program that will begin in June 2021. Is that correct?
So the TUF committee really only grants $75,000 per year. This is for the 1-year funding stream. That is not enough to cover a program that includes direct services like group support, like emergency support following deaths on site. So what it covers is a needs assessment, which would really be a 1.5 person team. So it doesn't even include direct services. This is the catch that we are always in within social services, that projects do have to start small, often with needs assessments, but we know that the way that works, we are years and years too late.
And so therefore, if the TUF funding does come through, you're essentially hiring people to do the research to assess what the bigger needs are. So you can build a case for it. Okay, thank you.
Yes.
Okay, I appreciate that. Thank you.
Okay, thank you very much, Juno. Our next speaker is Melody Alderton-Ballack from Street Health, followed by Kessla Forsyth, followed by Daniel Bingham. Melody, do we have you on the line?
Hello, good afternoon. Can you hear me okay?
We can. Welcome to the Board of Health. You can begin when you're ready.
Wonderful. Thank you so much for this opportunity to speak today. I'm Melody. My pronouns are she, her. I'm a registered nurse representing Street Health. I'd just like to say that I want to acknowledge the difficulty it is to get all this through in 3 minutes. And thank you for so much support from the rest of the community partners. It feels wonderful not to be the only one here. I want to echo everything that has been said so far by the other speakers, and mainly I'm here to voice my support for the recommendations given by the Medical Officer of Health to immediately scale up prevention, harm reduction, and treatment services, and provide immediate funding and reduce the barriers to implement the urgent public health needs site in all of our physical distancing hotels. So as we know, like 3 months ago, August was the worst month ever for overdoses. Then it was September. Then it was October, and 28 people died last month from suspected overdoses in Toronto alone. So we're breaking records in the worst possible ways. We're losing daughters, mothers, aunts and uncles. We're losing friends, brothers, community members. And as a frontline worker, we're standing with those who are left behind, witnessing this tragedy, and there's this increased feeling of hopelessness. So we know that most, if not all, of the opioid overdoses and the deaths are accidental and a direct result of the criminalization of drugs and drug users. We also know that it's a fact, not an opinion, that the current drug supply is poisoned. People are obtaining street drugs that are tainted with benzodiazepines that do not respond to naloxone, and also and even additionally tainted with extremely powerful opiates like fentanyl, which are leading to increased complexities during an overdose response. So I'm here today saying that we do need to decriminalize, but until that happens, we need more support for our safer supply programs. Our prescribers right now need expanded access to a wider range of medications, so those are injectables and stimulants, in order to provide effective services. I'm also here as part of my job is outreach, and I've been out to the camps, I've been out to the hotels, and one of the 6 demands for immediate action from the Encampment Support Network is that all shelter and supportive housing sites must be user-friendly and include robust overdose prevention and harm reduction services. So our OPS here at Street Health lost funding in 2019. We operate 100% on private donors. And I have to say, the reason I'm here today that really shook me is I realized that as a nurse working in a homelessness crisis, an opioid poisoning crisis, and now a pandemic, I actually don't want to work anywhere that doesn't have an OPS. I need the trained expertise of our OPS staff to help support me so I can actually do my job. And I started this before naloxone was a household name. I've been to overdoses in alleyways, in bars, in homes, in hospital settings, everywhere in the community. And I have to say, like, I feel the most confident when I'm here with my OPS team. So as a nurse working through these, that's what I'm asking. And I think that has something weight that some other nurses also agree with. So again, I see my 3 minutes are up, and I wanted to echo what my colleagues are saying, and that we need to get these OPS sites open inside our hotel programs immediately, because I know nurses there are responding with 911 and high dose naloxone, which is not necessarily putting additional strain on the healthcare system, and that's preventable. Thank you so much.
Melody, thank you so much and for your work. Let me open it up. Are there members of the board who have any questions for Melody? Seeing none, Melody, thank you again, and thank you for your work. Next up, we have Kesla Forsyth from the Regent Park Community Health Center, followed by Daniel Bingham, followed by Angie Hamilton from Families for Addiction Recovery. Kesla, do we have you on the phone? Kesla is not present, I'm told, okay? Which means we are next proceeding to Daniel Bingham, followed by Angie Hamilton, followed by Zoe Dodd. Daniel, do we have you on the phone?
Yes, I am. Can you hear me?
I can hear you loud and clear, Daniel. Welcome to the Board of Health. You'll have 3 minutes, and you can begin when you're ready.
Great. Good day, board members. I want to thank you very much for this opportunity to speak. My name is Daniel Bingham. I'm a member of MAC and the Neighborhood Group Community Center in Kensington Market. I have over 50 years lived experience connected with drug use and homelessness and depression. I've spent time in many detox centers and sober house residences. With the help of social support agencies and community NPOs, I'm now back on my feet and proud to say I'm off government support. Now, while working shifts at the drop-in center as a peer support worker, I've been able to help others navigate through this complex and sometimes confusing system. And I'm finding the people, because there's not an established setup, that the clients are fearful of coming in and trying to access help. Now, the group that I'm with is the Member Advocacy Committee, MAC. And we make efforts to advocate and to help support many people who need it. MAC has also created a harm reduction bill of rights, which I can present on if anybody asks. Now, this is to try to entrench these rights for all, drug users and people in the system to have a right to health care, right? During this pandemic, the number of calls from paramedics has been reduced. While unfortunately, there's been an increase in these calls that have ended up resulting in needless death. We must do everything possible to fix this. Now, when reading for today's agenda meeting, I found in the synopsis something interesting. Now, while of course I applaud all the measures stated and certainly hope they all get approved quickly, I've noticed at the bottom of the recommendations that it is stated that there will be no financial impact resulting from the adoption of these recommendations. I don't believe this to be exactly true. While support services that have been provided have been done in emergency response style method, we believe that an established, reliable drug use response infrastructure would reduce the costs to the overall tax base, because the cost of active working infrastructure is far cheaper in the long run than a constant, never-ending emergency response style would be. And that's the way I see the situation at this time. Thank you, board members. To wrap it up, I'd like to take the time to address the work of councillors Joe Cressy and Gord Perks, who've been arduous in their efforts to make sure these desperately needed measures will be implemented. It is my sincere hope that many other members and councillors will take inspirations from these gentlemen and do everything possible to help them achieve these goals. Thank you very much for your time today. Yours in service, Danielle R. Bingham.
Danielle, thank you for being here. Let me open the floor. Are there any questions for Daniel? Okay, seeing none. Next, we have Angie Hamilton from Families for Addiction Recovery, followed by Zoe Dodd, followed by Sarah Gregg. Angie, do we have you on the phone?
Yes.
Welcome, Angie.
Thank you.
Thank you for the opportunity. I want to support actually all the previous speakers and their recommendations, and support the recommendations of Dr. Davila. I was before the board in June, and I'm not going to reiterate all the reasons for decrim and everything else that I put forth at that time. What I would like to do is maybe provide a little bit of a deeper understanding of what families with minor children are going through right now in the province of Ontario, trying to actually save the lives. So first of all, minors do struggle with addiction to fentanyl. And it's very hard to have a child who is basically self-harming to death. That's traumatic in and of itself. But there is an equal amount of trauma to our families from the lack of response, any kind of response from the province. So there are two problems here. The first is a lack of treatment on demand, which I would say is the primary enabler of addiction. Everybody knows often people don't want help. And so when they want help, you need to strike while the iron is hot. And we have no capacity to do that. And for minors, it's even worse. So we have 2 long-term treatment centers, Portage and Pine River. When I started this work 5 years ago, the wait list at Pine River Institute was 14 months long, and there were over 200 kids on the wait list. It hasn't changed in 5 years. Notwithstanding all the announcements of all the money, I don't see any of it actually going to treatment of kids. I don't see any commitment to reduce the wait time. So that's number one. The second problem is kids don't want help. This is just a fact. It's often the case for various reasons. And in Canada, there's a view that it's terrible for people to be on a wait list. There's widespread recognition that that could be a death sentence. For some odd reason, if they're waiting for treatment because they aren't seeking treatment, well, that's just fine. From a family perspective, that's not just fine. And this culture does not exist in the US, where parents can require their kids to get treatment for substance use disorder, which in Canada apparently is viewed as a punishment. So the truth of the matter is, pre-COVID, every year Canadian parents take to their kids. Some Canadian parents are taking their kids to the States for treatment against their will. So, in fact, we have a 2-tiered treatment system in Canada. Those who have the know-how and the financial means to take their kids to the States for treatment, and those who do not. And contrary to popular belief, I do not think that that is a violation of their rights. I think that is protecting their rights. And it's odd. Canada has signed the UN Convention on Rights of the Child, and Article 33 says we have a duty to protect minors from illegal substances and the drug trade. The US has not signed that, yet we continue to let our youth play Russian roulette with their lives because they apparently both want to. If we had the ability to mandate treatment, the 14-month wait list at Pine River Institute would probably go to 14 years. So the fact of the matter is we have absolutely no capacity in the province of Ontario to treat our way out of this, even if we wanted to. And if we started to ramp that up right away, it's not available for the kids who are overdosing now. So 1 in 6 deaths in 2018, by the way, of kids 15 to 24 was opioid related. We have a duty to protect youth, whether they want treatment or not. And the ways we do that is we decriminalize drug possession to ensure that they're more likely to reach out for help and to ensure that they don't get a criminal record while they are waiting for treatment. We need treatment on demand, clearly, but also we need a safer supply, regardless of how young the kid
Angie,
is.
we're over, you're just over 3 minutes,
Okay.
so I'd ask if you could summarize in conclusion, please.
To summarize and conclude, the status quo in Ontario is causing trauma to families. It is not only unacceptable, it's unconscionable, and it is a dereliction of our duty to protect minors. Thank you.
Thank you very much, Angie. Let me open the floor. Members of the board, are there questions for Angie? Okay, seeing none, thank you. Just before we go to our next speaker, we have 8 speakers remaining before we move it into committee. And I would suggest, if it's the will of the board, that we move a motion to complete this item, as it is our final item. That way we do not risk losing quorum. And so I would move that the board extend its meeting past the scheduled 12:30 lunch recess to complete the agenda, which is this item. So that is on the table. Let me ask all those in favor. Okay. Any opposed? That carries. So we'll move to complete. So our next speaker is Zoe Dodd from the South Riverdale Community Health Center, who will be followed by Sarah Gregg from the South Riverdale Community Health Center, who I understand will be speaking alongside Roderick Main, who is listed further down the list, who will be speaking alongside Sarah. So Zoe, welcome. Thank you for being here. And when you're ready, do we have you on the line?
Thank you. Can you hear me?
We can hear you loud and clear.
Okay.
Thank you, Zoe.
Great. Thank you. So thank you for letting me speak today. So we've tried everything: silence, marches, direct actions, deputations, consultations, screaming, crying, being at your tables. We tie ourselves up in knots trying to get a proper response from all levels of government. We are shouldering a crisis without the supports and resources that a public health emergency would offer, and trying to think of how to describe it to you and how it feels right now reminds me of Vito Russo's speech outside the Department of Health in Washington, D.C. in 1988 during the AIDS crisis, when he said, "Living with AIDS is like living through a war, which is happening only for those people who happen to be in the trenches. Every time a shell explodes, you look around and you discover that you've lost more of your friends, but nobody else notices. It isn't happening to them. They're walking the streets as though we weren't living through some sort of nightmare, and only you can hear the screams of the people who are dying and their cries for help. No one seems to be noticing." And this is how it feels in the overdose crisis: people finding dead people in beds, porta potties, doorways, homes, responding to thousands of overdoses, losing loved ones, friends, colleagues, family members. The ripple of death is grim and will take decades for people impacted by this loss to heal. The city has power and tools that we have seen implemented to shift resources around to respond to COVID. And even today, there are no recommendations made directed at what the city could do about the overdose crisis, which has been with us for even longer years. We're abandoned by all levels of government who point fingers at one another, and we are burning out and people are dying, including our colleagues. I'm not going to plead with you. Instead, I'm going to use the rest of my time here for a moment of silence to think about the hundreds of people who have died this year in Toronto. I'm going to use this moment to think about those who I knew who passed and those who didn't. And I'm going to ask you to reflect on what more the city could be doing, to think about all the preventable deaths, and to ask yourselves if you truly believe that you have done enough. So I ask you just to let me use this time for a moment of silence and think about who we've lost.
Thank you, Zoe. I'd ask members of the board to join me in a moment of silence until the conclusion of 3 minutes.
Thank you.
Thank you very much. Let me open the floor. Are there questions from members of the board for Zoe? Okay, seeing none. Thank you very much, Zoe. Our next speaker I have is Sarah Gregg from the South Riverdale Community Health Center, and I understand that Sarah is being joined on the phone by Roderick Main, who is also listed further on the list, and Christy Jewell, who was the final deputant who registered to speak on this item. So Sarah, Roderick, and Christy, do we have all three of you on the phone?
Hi, Joe, we're here.
Okay, so what I'll do with this is a combined presentation, and so you have
Well, actually, there was, you know, we registered as three separate people. We're just sharing a device here.
Yeah, no, and that's what I was about to say. So it is a combined presentation, so you'll have 9 minutes all told together if you need the full 9 minutes.
Thank you.
Thank you.
Maybe I'll start. My name's Sarah Gregg. I'm the current manager at the Moss Park injection site. And what I thought I would talk a little bit about today is what it's like being a human being and doing this work. So in the past 3 years, I've responded to around 2,000 overdoses. That's a really big number, guys. I've responded to and reversed almost 2,000 overdoses in the last 3 years. The majority of them have occurred on site, where there's access to the tools and the equipment that we need to successfully save lives. Other times, I've responded to overdoses in parking garages, alleyways, and bathrooms, in the middle of city streets with traffic, whizzing by me. I've responded to overdoses in stairwells and in parks and in people's homes. And I will say that it's so much more difficult to respond out in the community when you don't have the tools necessarily that you need to do the work well. There's been times that there's been so many overdoses in the Moss Park neighborhood that now the community members know us and will literally stop traffic and direct traffic for us when they see us running. And people will come and bang on our door because they know that we can often respond faster than paramedics and without police accompaniment. So when I respond to overdoses, particularly when you can see that the person is already blue, it's like I'm looking through a tunnel and all I can see is the person who's on the ground and the rest of the whole world fades away around me, and the sound fades away too. So in the moment, I can hear my own voice when I'm shouting commands at people or when I'm coaxing someone to breathe. And then I zero in on the sounds of breath and spontaneous breathing, which is a good indication that what I'm doing is working. And then I can also hear the voice of my partner who I'm working with as we're communicating with each other to try to save a person's life. But everything else is gone. It fades and it's just a tunnel. And time slows down and it speeds up all at the same time. And if it weren't for the second hands on a clock, it's like time itself is all an illusion. And I become really zeroed in and working in autopilot. And it happens this way until the person starts breathing again or becomes responsive. Then it's like the world takes shape again around me. On the days that there's been so many close calls or multiple overdoses, I sometimes stay in that tunnel for a long time, right? Or sometimes it broadens a little bit, but it's still there and it's at the ready to help me focus when I need that zero in and that focus. And on these days, I startle when I hear sirens or shouting or sudden noises. And on these days, I sometimes feel tingling in my fingertips because the stress hormones have redirected the blood flow in my entire body. And then afterwards, there's always the crash, right? There's always this adrenaline crash. And it doesn't happen until it's safe to do so. So sometimes I'm operating with this heightened adrenaline for such a long time. And then when the crash comes, it's sometimes really, really pleasant. And other times it's really sad.
Sarah, I don't mean to interrupt. You're just over 4 minutes if you could seek to.
That's fine, yeah. And in this time, I've learned how to ride the waves, right? And I feel really lucky that I'm a person who is housed, and when I'm done working in the trenches for 15 hours, I get to go home and I can shut everything off. And I also acknowledge that other people don't have this luxury and they don't get a break from it. And there's very little time in between emergencies to process the complexities of the trauma that they've experienced or responded to, or the grief that we're impacted by. And what I want everyone to know on this call is that this work is changing us as human beings. It's changing our brains and it's changing our hearts as well.
Thank you, Sarah. And as we're taking these in order, we can come to questions for all after. I next have Roderick Main. Roderick, do we have you on the line?
Yes, you do.
Roderick, you'll have 3 minutes when you're ready. Welcome.
Thank you. Hello, my name is Roderick Main. I'm a service user at Moss Park Convention Site. I'm on the Safe Supply program right now. As a user of the Safe Supply program, I think we should change it to adapt to the new circumstances. We should look into providing Safe Supply with medical grade injection heroin like they have in BC. And I also think there should be 24-hour safe injection sites to be available, as there's large stress on all the injection sites. It's hard to get everybody in and keep people off the streets. I also think maybe there should be a bus that comes around instead of an ambulance with people that have the supplies like oxygen and stuff to help reverse overdoses. I also think the decriminalization of simple possession of all drugs with stimulants and opioids is a very essential thing, because sending these drug users, it's an illness. It's not an addiction. To be sending them to jail is not going to help. They need here and now, and they just need here and now. We need to keep funding for these places to run, because as you know, there's reports done every night to so you guys can give us funding. So we ask that we can get more funding. Part of the addiction is like there's trauma behind it and grief. That's a big thing. As my brother passed from overdosing, and there wasn't the supplies around to reverse that overdose, so I've lost one of my own, and that's kind of why I do this work. I think that the drug coverage program, so they could cover the injectable heroin or injectable Dilaudids, because yes, there are tons of people who are killing. We need safe supply to stay alive. When people don't get what they need, they just go back to the streets and the drugs and overdose. I just need something safe to use. The pandemic is all about statistics, and every day we hear about the stage we're in and how many cases there are. But no one is talking that way about overdoses, and the number of overdoses and deaths keep getting worse. We need to take action now to save lives. And I just like to, again, thank everyone for listening to me, but I hope you guys can take this in real live time action, because something needs to happen now. Here you go, Christy.
Thank you very much, Roderick. And I have the third member for this delegation, I should say, for the three of you speaking, is Christy Jewell. Do we have Christy on the line?
Yes, I'm here.
Welcome, Christy. Thank you for joining us. You'll have 3 minutes, and you can begin when you're ready.
Okay. Good afternoon. My name is Christy Jewell, and I am a service user daily at the Moss Park consumption site. And here's my story. I was on methadone for 6 years. I had my carry for 2. Eventually my health card had expired. I was clean at the time, had a job, had a house. And because my health card had expired, I was instantly kicked off my methadone. And so what do you do when you are sick? You get unsick. And how do you get unsick? You go on the street and find drugs. Because opioid addiction is more of a dependent thing rather than a mental thing. And I think that's something that's very misunderstood by many people who haven't experienced or spoken to people who have suffered opioid addictions. Um, and I had a really hard time with this because also I was not homeless at the time. I was renting a rooming house, and I couldn't get my ID because I had no piece of email with my name on it. But eventually, this addiction led me to become homeless. And so through them, eventually I learned with the ID clinic, and just within the last 10 years of being on the street, just recently received my health card. I think simple possession should not be illegal. I think it's ridiculous to go to jail when you're just trying to get through the day unsick without withdrawals. The overdose crisis, I see it as more as a mental health crisis, more than a substance use crisis. Most substance use, in my experience, has been from a past trauma. If you have a history of addiction, you shouldn't be penalized for it. I think you should be helped. I see addiction as a mental health and trauma issue, not a legal issue, and we have a right to our health, our well-being. When I get out of jail, I can honestly say that I'm afraid for my life. When I leave those prison doors, those jail doors, I am afraid for my life. I'm afraid to die. We need to also get funding for overdose, grief, and trauma support. We've all been traumatized. We all lost somebody that we've known to overdose. You become eventually desensitized to it because we don't have grief groups for overdose. And you don't want to continue using because you've lost so many people to it. But where do we go? Where do we turn? Where can we fix this? You know? And that's where the safe supply comes in. But I was hoping, you know, if you guys looked into the statistics of Vancouver's heroin program and see the success rates there compared to the success rates of the program that we have here, I would bet some money on it that it would be much more successful. Why? Because the dilaudid are much lower grade opiate than fentanyl itself.
Chrissy, I don't mean to interrupt. You're just over 4 minutes, and I wonder if you could seek to conclude in a sentence, please.
Okay. So, and also, when you hear that people die, they die at night. So we need a 24-hour somewhere site, whether it's like Roderick mentioned, a van. We also need to put out some vending machines that are accessible 24 hours a night, where we can get some clean kits and some clean supplies and have access to naloxone.
All right, thank you very much.
I also think
Chrissy, I'm going to have to, I'm afraid you're just over 5 minutes, and so I'm going to have to conclude it there. Thank you very much.
Okay.
Thank you. So to Christy, thank you, as well as Roderick and Sarah. All three spoke there at request, one after another, and so I'd open it up to the board if there are any questions for Sarah or Roderick or Christy. Okay, seeing none, thank you to all three. Our next speaker is Robert Wilson from St. Stephen's, followed by Jolene Hughes from South Riverdale, followed by Dr. A.J. Withers. Robert, do we have Robert Wilson on the line? Robert, I'd ask you to just connect your mic, please. Robert, do we have you on the line? Okay. What I'm going to do, I'm going to ask you to continue to work to connect your mic, and in the meantime, I'll come back to you, Robert. In the meantime, I'll proceed with Jolene Hughes. Do we have Jolene from South Riverdale Community Health Center? Jolene, do we have you on the line?
Yeah, I'm here. Can you hear me?
We can hear you loud and clear, sorry. So Jolene, you'll have 3 minutes, and then I'll go back to Robert Wilson, followed by Dr. A.J. Withers.
Thank you. My name is Jolene Hughes. I'm with South Riverdale Community Health Center. My role here is with the Safe Opioid Supply Program as a community health worker. My pronouns are she, her, and I would just like to acknowledge that I am on Indigenous land serving our population. So in terms of the Safe Supply Program, the goal of the program is to provide safe opioid supply to address the opioid crisis by transitioning people away from toxic and contaminated street opiates to pharmaceutical grades such as Cadian and Dilaudid. It's not perfect. If we could have a larger range, we're working against fentanyl right now. And if our prescribers could have a vaster range to support the crisis, that would be great. The program has eligibility criteria that select people who are at the highest risk for medical complications related to street opiates, such as fentanyl. Each program across the Downtown East is staffed by a nurse practitioner, a community health worker, and a nurse. We collectively see 250 people. That is what our target is for the end of March 2021. That's about 83 people per site. Since July 2020, 41 clients have been accepted to the program. All clients require ongoing assistance with accessible, stable housing, intensive case management, and primary care. Right now, in terms of the successes, significant reduction in use of street opiates prior to program self-reports of 10 to 15 points a day, down in some cases to 1 to 2 points a day. In some cases, there are no use of street substances. There's a significant reduction in injecting and transition to oral consumption from previous injection use. There's a significant reduction in illegal activities, significant reduction in spending money on street drugs since the Safe Supply Program. Medications are covered through insurance. The average person is spending $100 to $200 a day on street supply, which is $3,000 to $6,000 a month prior to Safe Supply. Our challenges are that there is a limited capacity for enrollment in the program due to staffing and funding. We need more funding. Limited options for housing at this time. Many of our clients are currently homeless at 83% or more, making it very difficult to medically stabilize a person. Our options for volunteering, drop-ins, and social interactions, as well as food programs, are almost non-existent due to COVID. It's difficult to follow up with clients who lack access to transportation, phones, or the internet. The trauma to the community, peers, and staff and families is huge. There is a large gap for funding for trauma support. We're also working with intergenerational trauma, primary and secondary trauma. The lack of access also to psychiatric care has been challenging. And last, I will finish on the note that the population of need for the Safe Supply Program are fatally overdosing prior to us being able to access them to get them on the Safe Supply Program. Thank you.
Thank you very much, Jolene. Let me open it up to the board. Are there questions of Jolene? Okay, seeing none, thank you so much. We're now going to try again with Robert Wilson from St. Stephen's. Do we have Robert on the line now?
Hi, it's Robert here.
Hi, Robert. We can hear you loud and clear. Welcome. You'll have 3 minutes when you're ready.
Okay, great. Hi, my name is Rob Wilson. I just want to start by letting my team and all the people working the front line in the overdose crisis that I'm so proud of them. Like I said, my name is Rob. I've worked at St. Stephen's Overdose Prevention Site for about a year now. What I've seen during the COVID is a lot of more friends, family, and community passing on, and it's so sad. We are spread so thin, especially as an unfunded site. We have to run our overdose prevention site with very little money. We are struggling with so many lost clients. It's happening almost weekly. Now during the pandemic, everyone is burnt out and tired. I came to this work because I have been deeply affected by the overdose crisis personally. I lost my son to fentanyl overdose. I can't even begin to count how many friends I've lost over the years I sit and wait every night for my brother to call, worrying that he might have overdosed and died somewhere. It's so stressful. COVID has made everything worse. People don't have access to their community or their spaces that keep them safe. I don't want to sit here and talk about death for 5 minutes, but that's all there is. The crisis has taken too many innocent people, young and old, to heaven way too fast. We're waiting far too long and lost too many people. We need safe supply option, overdose prevention, and housing and shelters, more low barrier 24-hour prevention sites, and grief and trauma support for frontline workers facing death and loss every day. Harm reduction has come a long way, but it needs to go further. Overdose deaths were a pandemic long before COVID hit, and it's only going to get much worse. However, we know how to flatten the curve with the overdose pandemic. It takes more overdose prevention sites and better access to safe supply. The numbers don't lie. I really hope, for the sake of my friends, my family, my community, my coworkers, that action is taken today. Thank you.
Rob, thank you so much. Rob, thank you so much. Let me open it up to see if there are questions from members of the board. Okay, seeing none, Rob, thank you. We're now going to go to Dr. A.J. Withers, followed by Dane Kent.
Of my friends, my family, my community.
Sorry, I think we lost you there, Rob, but thank you. So we're going to Dr. A.J. Withers, who will be followed by Dane Kent, followed by Emmett O'Reilly. Do we have Dr. Withers from the Critical Disability Studies Faculty of Health here? Seeing none, Rob, thank you. We're now going to go to Dr. A. Sorry about that. There was a technical glitch there, so we'll try that again. Do we have Dr. Withers on the line?
Hello?
Hi, do we have you there? Dr. Withers, I heard you a moment ago. Can you try again? Jay Withers, followed by Dane Kent.
My friends, my family, my community.
Okay, what I'd ask, Dr. Withers, is you're going to have to turn off your YouTube link.
We're going to Dr. A.J. Withers, who will be...
Because there's a delay with following on YouTube. So, Dr. Withers, having closed the YouTube link, can you now hear us?
Followed by Dane Kent, followed by Emmett O'Reilly.
Okay, I'm going to ask our recording secretary to mute that mic. We're going to try coming back to you. So Dr. Withers, we're going to try coming back to you. I'd ask you to turn off your YouTube when we come back to you. Dane Kent from the Moss Park Overdose Prevention Site. Do we have Dane on the phone?
Hi there, can you hear me?
We can. Welcome to the board. You'll have 3 minutes when you're ready.
Okay, thank you very much. My name is Dane. I work as a community health worker at the Moss site. I've been involved in supervised consumption ever since the inception of our trailer in Moss Park. I'd like to thank you for the opportunity to address this issue here. Thank you, Chair. I'd like to start by saying every society will have members who are substance dependent, not because of any moral failings on the part of the individual, but rather because society will always create substance dependent members. It is possible to prevent horribly traumatic things happening to people who are young and unsupported. Those who end up in a street-based substance dependent reality overwhelmingly have histories of severe childhood trauma. People who have endured experiences that are too dark to repeat in public spaces. They are beaten and chained to stairs, forced into sexual slavery by their family. They witness murder and violent assaults against the people that they love, or been kicked out of house and home for coming out as LGBTQ. In all of these experiences, they're the victims, not the perpetrators. They carry these memories with them everywhere they go, living a life way down the backpack of trauma and suffering. For many, substance use becomes the only fleeting opportunity that permits them to take a backpack down. In my experience as the coordinator of the program at Moss Park, I've seen every sample we have submitted over 100 days. I've seen fentanyl levels ranging from 1 to 97%, which makes consistent dosing impossible, drastically increasing the risk of overdose. In order to save money and preserve the sedating effects of opiates, you have introduced a variety of adulterants like atazolam, flualprazolam, and novel benzodiazepines. These drugs have long-lasting effects that make people unconscious for hours at a time. We routinely have to call EMS to hand off care for individuals who cannot regain consciousness no matter how hard we try to rouse them. If people had access to a regulated, safe supply, they could build consistency in their dosage and begin to stabilize their day-to-day experience. Our folks come to this site to manage their withdrawal and get well, expecting their shot to last a little while, often having plans to head off afterwards to appointments to see their ODSP worker, to meet with mental health counselors or outreach workers. But these plans go up in smoke when they inadvertently end up injecting heavily sedating adulterants. Our Premier Doug Ford suggested he wants these to provide rapid misses the point entirely. We need to dismiss a safe support. People with access supports more consistency and predictability in their supply. The war on drugs and drug prohibition just failed spectacularly. We adopt a new approach to mitigate the impact of substance dependency both on society and those who are dying preventable deaths from overdoses, because what we have done to date has not worked. Policymakers and our elected officials need to realize that there will always be a segment of our population that has high impact substance dependency, and that fact will never change. Some people will always manage physical and psychological pain through substance use, either legal or illicit. Face facts, have some compassion, and try something new. If you want me to believe you when you say you want to address this issue of preventable overdose death and the carnage wrought from trying to enforce archaic prohibition laws, but you don't advocate for safe supply as a component of your plan, then you're not interested in solutions. Rather, you're merely playing lip service to this issue so you can add it to your policy bullet points on your campaign mailers in order to garner votes. Be on the right side of history and listen to the people who have actually spent their time doing this work, who have conversations with those at high risk of overdose and know solutions that will work for those who need them. I thank you for your time and allowing me to express my position on this issue.
Thank you very much. Open it up from members of the board. Are there questions for Dane? Okay, seeing none, I'm going to try going back to thank you, Dane, very much. I'm going to try going back to Dr. Withers to see, and followed by Emmett O'Reilly. Do we have Dr. Withers?
Hello, can you hear me?
We can hear you loud and clear. Welcome. You'll have 3 minutes when you're ready. Thank you.
Perhaps someone can just indicate in chat if you can hear me, because I can't hear anything. I apologize. Okay, great. So I apologize for whatever has happened. My name is AJ Withers. I have a PhD in social work, and I am faculty in critical disability studies at York University. My pronouns are they, them. And I want to adopt the comments of many of the prior deputants. I also want to commend the medical officer of health for several of the recommendations in this report, or for all of them actually. However, it's insufficient. The report contained no financial recommendations. No financial recommendations as the city spends, billions on COVID-19. With COVID-19, we have seen what the Toronto Board of Health is capable of when something is considered an emergency for the full population, for non-marginalized, non-entirely marginalized population. And I'm asking you today for 6 emergency public health motions in addition to those in the report. And these cost money because they are tangible and they're meaningful for communities immediately. The Toronto Board of Health recognizes that criminalization is not an appropriate way to deal with drug use and addiction issues, and these are health issues. At the same time, the city has enacted a policy of displacement and decampment, which multiple homeless people who live in encampments and the scholarly literature all identified as criminalization. The threat of eviction is used as a coercive measure to remove now criminalized people who are disproportionately Black and Indigenous, out of the parks and into shelter hotels or plexiglass cages in the Better Living Center. When these moves are coerced, people are less likely to move with people that they feel safe with. They're more likely to be disconnected from their supports and increasingly vulnerable. And these can possibly lead to increased likelihoods of overdose deaths. And the report released by a number of provincial bodies found that there's an alarming increase in overdose deaths in shelters, hotels, and inns. And we saw a number of increases in overdose deaths in the shelter hotel system as well. Today, you need to pass an emergency health measure motion to stop the criminalization of homeless people in encampments, reinstate the moratorium on evictions of encampments from city properties. We need you to pass an additional motion for at least 2,000 shelter hotel beds added into the system immediately, so there's sufficient space for people to freely leave the encampments and go to appropriate locations. So this is necessary emergency public health measure that will help address the overdose death crisis and the COVID-19 pandemic. So stop using a hammer, stop criminalizing people, and help actually give people the space to freely choose. I also implore you to pass additional 4 motions today that call on the province to expand safer supply and for safer supply to be offered in shelter hotels and in shelters. Number 2, for the Toronto Board of Health to secure long-term funding for operating OPSs, as we heard from the person from Street Health, they don't have funding. Number 3, because the medical officer of health recognizes harm reduction as an emergency essential service, that this needs to be available in shelter hotels, shelters and respites.
And Dr. Withers, I don't mean, I hate to interrupt, you're just...
I apologize, and I can't hear any warnings I may have. This is the last one. Councillor Kristen Wong-Tam's motion at council to no longer make it illegal for city-funded agencies to distribute survival supplies was a necessary step, but it needs to be backed up with emergency health funds immediately. Okay. So these are the 6 motions that I'm asking for you to pass today. They cost money. Emergency health things actually require funds. We're in an emergency. We've seen what this board can do.
Dr. Withers, I know you can't hear us. You're just coming up on 5 minutes.
For the most marginalized people in this deadly crisis that we've been in for far too long. Thank you.
And I believe, thank you very much, Dr. Withers. And I understand we could hear you loud and clear for those tuning in. Unfortunately, I understand you can't hear us, but rest assured we heard you loud and clear and received your deputation. So thank you very much. Our next speaker is Emmett O'Reilly, and then there are 2 speakers following, Jessica Demera, followed by Paula Tukey. Do we have Emmett on the line?
Yes, I'm here.
Welcome, Emmett. You'll have 3 minutes when you're ready, and we hear you loud and clear.
Good morning. My name is Emmett O'Reilly. I'm a nurse practitioner working with the drug using communities and overdose prevention sites in Toronto. Before I begin, I just want to associate myself with the previous remarks made, particularly the one from the previous speaker about trauma care. Trauma is driving the overdose crisis and being driven by the overdose crisis. And for almost all my clients, it is impossible for us to get competent ongoing trauma care. It is also very difficult for us as providers who are experiencing trauma from this crisis to get any help. So I would really throw my support behind those comments. As the other speakers have noted, there's a significant increase in overdose responses in our overdose prevention site. This accords with the simultaneous alarming increase in overdoses deaths that we've seen across the city and the province. Overdose prevention sites are absolutely essential in responding to the overdose crisis. That said, the model essentially requires highly skilled teams of people to stand by as people from their communities that they care about inject substances that we know are highly likely to be lethal. And then when the inevitable happens, only then can they act by pulling them back from the brink of death. And I think we've heard very compellingly how brutal that is on the people providing that care and the communities of the people to whom that care is provided. This is one of the clearest examples of a downstream solution I have ever seen, and it's simply unsustainable and will not provide enough to reduce or reverse the overdose crisis. We need to address the toxic supply. I would like to add my voice to the voices of the community of drug users in calling for decisive intervention in the supply of drugs. I participate in the delivery of one such intervention, which is safer opioid supply. Under this program, we prescribe medications of pharmaceutical quality and known potency, which participants can use as they see fit. This is proving to be a highly effective intervention. Again, this is highly limited intervention and should only be seen as part of the solution. We join our community in calling on all levels of government to make space available for community to lead responses to this crisis. In addition to innovative medical practices like safer supply, we need to offer the community de facto criminalized spaces to access safer supply. This would allow the community to care for itself. Fires clubs, satellite harm reduction sites, and supervised injection sites in Toronto community housing are only some of the suggestions being put forward. Toronto has provided de facto decriminalized spaces before and can do it again. I implore you to engage with the community and take brave and bold action now. If you do not, we will continue to mourn the loss of people we are charged with caring for, and we will have to deal with our own significant role in those deaths. Thank you very much.
Thank you very much, Emmett. Are there any questions for Emmett? Okay, seeing none. Thank you, Emmett. Next up is Jessica Demera from the Center for Urban Health Solutions, followed by our final speaker, Paula Tukey. Do we have Jessica on the line?
Yeah, I'm here. Can you hear me?
We can hear you. Welcome, Jessica. You'll have 3 minutes when you're ready.
Okay, wonderful. So I'm going to try to be as fast as I can, and I'm just grateful I'm not the final speaker as well. I do want to thank for the land acknowledgement, and I would also like to point out, as a proud and strong Métis woman, that today is actually Louis Riel Day as well. So you can't see me, but I've got my sash on right now. Didn't make it to the flag raising, but anyway. So I'm going to start. My name is Jessica Demre. I'm a Cree Métis woman, originally from Saskatchewan, who's been in Ottawa and Toronto the last 15 years where I live, work, and play. I've worked with Indigenous communities and Indigenous health for almost 20 years. I've worked at the National Aboriginal Health Organization, the Assembly of First Nations, the Canadian Public Health Association, and most recently, when I moved here to Toronto, I created the Indigenous Research Program at the Ontario HIV Treatment Network, and most recently with Well Living House, and now supporting the work of my scientist, Dr. Michelle Firestone. Like others, when COVID hit, I redeployed. That's not entirely true. I really did redeploy myself with the support of my supervisor as I anticipated gaps in some of the emergency measures that were going to be implemented fast, like the hotel shelter programs and serving Indigenous community members in a good way. To that end, I do outreach when needed and have been in the shelter temporary hotel programs as well. I can only say that in my experience, those individuals in those capacities and centers are the most committed people that I have ever met with, and I'm humbled to be in their company. Today, I use the term community member as that's how I'm presenting. I live in multiple worlds, as many people do. I'm part of the urban Indigenous community, also a service user who has been by COVID. My ancestors walked before me and give me the courage to be able to speak today. I also have behind me the support of the Ontario Aboriginal HIV/AIDS strategy, two-spirited people of the First Nation, the Toronto Aboriginal Services Sector Council, member agencies, as well as my hundreds of allied non-Indigenous frontline workers to present this group statement. I am here today, though, while my colleagues are literally outside doing the absolute necessary work that they need to create. So I'm going to skip over some parts because people did already speak to some of what has already been spoken to. I do support the recommendations of the Medical Officer of Health. I do support the absolute need, the dire, urgent need for grief support that we're all facing. So I do want to respond, though, from our Indigenous perspective. When COVID hit, we responded almost immediately. Our informal networks and pathways have resulted in formal interventions. We created mobile testing with Women's College Hospital in the encampments, Anishinaabe Health Toronto with the mobile bus that is going out delivering testing, as well as participating in the creation in the standalone COVID site center at Name Res. There are many other coordinated activities that many of us in a volunteer capacity since March have even done on our own with absolutely zero or infrastructural support from both the city, the province, and the federal government.
And Jessica, you're just over time, so I'd ask you to seek to summarize and conclude. Thank you.
Okay, so my issue, and for all of us in the Indigenous community, the city has been sitting on a Board of Health Indigenous overdose strategy since February 25th, 2019. Nothing has been done. It is convenient to talk about reconciliation for the city when it comes up, and the TRC recommendations have been accepted. So they're not recommendations. There's an ethical, a moral, and a fiduciary obligation and responsibility to make sure that the direct capital investments to actually address the opioid overdose do take place. So there is a need for funding and access to temporary and transitional housing. There's an absolute urgent need for dedicated funding for Indigenous harm reduction agencies and approaches. At present, everything is abstinence-based. Lastly,
Jessica, I'm just going to ask you to conclude in a sentence, as I'm afraid you're over 5 minutes.
Okay, so I'm going to say this. We've continued to work within the systems provided to us, even as a member of the Tough Advisory. Nothing is done. We are watching people die, and we have no one to go to. And like Zoe even said, what more can we do? I could produce evidence and reams of it. So now,
Jessica, you're at 6 minutes. I'm going to have to conclude you there.
Sorry.
Thank you very much. Deeply appreciated. Can I see members of the board if there's any questions? Okay. And our final speaker who we'll come to, thank you very much, Jessica, is Paula Tukey. Do we have Paula on the line? Paula? Paula, we have you connected if you want to unmute your mic. Okay, I'll try one last time for Paula. Paula, can I? Okay, with that, you're trying to connect again. I'll just make a note just before we try one last time with Paula. Members of the board, 1, 2, 3, 4, 5, 6. We have 7 members here, which is quorum, but this is quorum. So I'd ask for the 7 members who are here, Councillor Perks, Wong Tam, Layton, Trustees Donaldson and LaPretti, and Director Wong, if you could keep your video on to maintain quorum, I would be most grateful. One last try. Do we have Paula on the line? Okay. I'm very sorry for that, Paula. We will try again in a moment. We're going to move this into committee. I'm just going to try one last time. Paula, do we have you? Okay. I'm very sorry about that. We're going to move this into committee. Questions for staff. I have Councillor Wong Tam. Councillor, when you're ready.
Thank you, Chair. And through you to staff, recognizing that there's been a number of new facilities that have been opened largely to try to get people from staying outdoors into indoors. So therefore, it's a combination of shelter hotels as well as respite sites. And then, of course, they're also open to try to thin out the congregate settings in our shelters. Out of those facilities that have opened, I recognize that there are some facilities that have, I believe, some harm reduction services, as well as some that are in process of opening up on-site overdose prevention sites. Can you give us a status to that work?
Hi, Councillor, it's Gord Tanner here with Shelter Support and Housing. Thanks for the question and through the chair. So you're right. I mean, we've opened a number of new facilities, over 40 new facilities, 25 of them still open, 19 are hotel sites. And as we moved, upwards of 2,000 people into these settings, we have been working collaboratively with both our colleagues at Toronto Public Health and specifically the Works team, but also with individuals in the community health sector, the likes of South Riverdale and Parkdale Queen West. And really that work is to get staff out to these various locations first off, and they have been conducting a needs assessment with respect to the sort of needs of individuals at the sites and how we can bring more harm reduction supports to those sites. We have committed just recently over $7 million to fund enhanced staffing resources to do that outreach work, both with the Works and our colleagues at the city, but also with Parkdale Queen West and a group of harm reduction workers there. And really it's the credit and hard work of those staff that have been going out that's really been informing the kind of supports we need to build at those locations. So we are pursuing with Health Canada and through public health to understand the application process, to introduce a number of different interventions at those sites, up to and including the establishment of overdose prevention services as per the urgent public health criteria that's available through Health Canada to make that happen.
Gord, thank you. So it sounds to me the intention is to drive the service change throughout the system. So therefore, on-site supports for those who are using substances. Is that my understanding? Is that the understanding for the future?
Yes, Councillor, that's correct. And this funding is one time at the moment. It would carry us through till December 31st of 2021, so all of next year. And I think that through this collaborative work with the community health sector and harm reduction sector, we are striving to make that change throughout the shelter system.
Great, thank you very much.
We did manage to, and I promised to check one more time, we did manage to connect with Paula. Paula, do we have you on the line?
I am on a phone.
Okay, Paula, you are our final speaker today, and you'll have 3 minutes, and then we're going to return into committee for questions of staff. Paula, when you're ready, you can begin.
Thank you very much. My name is Paula Tuki, and thank you for your time. I'm representing the Keep Six Safe Consumption site at South Riverdale Community Health Center. I've been working on the front lines for the past 30 years, working exclusively with people who are homeless, who use substances, and experience mental health challenges. I'm now the manager of Keep Six Consumption and Treatment site. The opioid overdose situation has been critical even before COVID's impact. Since March, the suffering of our clients and the impact this is having on staff has been magnified manifold. We count the number of people who have died as a result of an opioid overdose, and that number is atrocious and still ever growing, but we have no way to measure or keep track of the damage done by repeated episodes of insufficient oxygen saturation routinely experienced during an overdose that will cause brain and organ damage. We are knowingly, and in the case of safe consumption supervised sites, under observation, subject substance users to consume poisons and then expect workers to deal with the poisonings. The scenes in a safe injection site are unimaginable to those who are not witnessing them. Service users in various degrees of consciousness, some lifeless, some flailing and combatant, some vomiting, some urinating themselves. Both service users and workers are experiencing ongoing complex trauma that is, for the large part, avoidable. We have all the tools needed to put a stop to this nightmare. We have already available all the substances people use, a pharmaceutical-grade medication. We need to expand what is being offered through the safer supply programs to include fentanyl and heroin, as well as stimulants. We need to expand access to these alternatives to anyone who expresses interest. During alcohol prohibition, countless people died or were permanently disabled by ethanol poisoning. We have recognized the harm and ended that prohibition. We have learned nothing from that experience. And since then, we also stopped to care enough to appropriately address the current state of poisoning in our communities. We need to end drug prohibition now, and we need to start offering safe alternatives that will stop the onslaught of death and poisoning. Inaction is immoral. Thank you for your time.
Paula, thank you. And thank you for bearing with us to ensure we address the technical challenge to make sure we could hear you today.
Thank you very much.
Are there any questions for Paula? Okay, seeing none, I'm bringing that back into committee then. We heard from Councillor LongTerm. Any other questions for staff? Okay, moving to speakers. I have Councillor LongTerm and Councillor Perks and myself. Okay, Councillor LongTerm, do you want to kick us off?
Yes, thank you very much, Mr. Chair. It seems almost impossible to sum up the grief and
And I think the heartbreak that this community of service providers that came before us to share their stories, and it's very difficult not just to hear, but also to understand how to get in front of it if we don't have the provincial and federal supports. And this is not a matter of finger pointing; it's just a matter of the jurisdictions that we have. And I think,
Councillor, you have an amendment. Sorry, I believe.
Oh, I do. Yes, thank you very much. My apologies. My amendment, if I can ask the clerk to put that on the screen, is to have Dr. Davila and this Board of Health to recommend that Dr. Davila work with the city manager to find emergency funding to fund trauma and grief support as needed and as quickly as possible. They don't need to come back to council. They just need to get this done. I think that we've heard quite clearly from the speakers that came before us today that they're at the breaking point, and if they break, there is nobody else to do this work. So at the very minimum, I think what we need to do is to provide as much immediate support to this community as much as possible, recognizing that we are not able to influence the entire sphere of all the different policies that need to come into effect to deal with the opioid crisis. And this is probably what's been so challenging for those who are on the front lines, is that they're asking everyone and anyone who will listen for support, but in some cases we have our hands bound by jurisdictional purview. But I believe very clearly that we can do this as a city. If we can't decriminalize, small possessions of narcotics, not that I know of right now, but we can't do that. There are other things that we can do. And I believe the other things that we can do is to support the workers that are on the ground and the advocates on the ground with the things that they're asking for. And although in the staff's presentation that perhaps the province should be providing grief and trauma supports, I believe that this is something that we can easily fund. We have seen the city manager as well as city council twist themselves into a pretzel during the COVID response. Sorry, I've been listening to 2 hours of construction while I've been listening to the deputations. But if I can't finish my remarks, it's the motion is there. But I just want to thank everyone who showed up to speak today. To save you all from the drilling above, I'm just going to conclude my remarks there. Thank you.
Thank you very much, Councillor LongTerm. Next up we have is Councillor Perks.
Thank you, Mr. Chair. And I think an important thing we must do is to take a moment and acknowledge the loss of life, the trauma, the grief that is being experienced in the city of Toronto today as a result of the opioid crisis. It is just overwhelming to even try to understand. And having worked for many years now with this community, I can tell you they're not exaggerating. It makes me wonder if we can even call ourselves civilized, that this is going on in our community, untended, unsupported. Councillor LongTerm and yourself, Mr. Chair, have motions to push to the limit, do everything that's possible within the City of Toronto purview. But we also have to acknowledge that what is at the foundation of this is somehow some leaders in our society, and I'm thinking here particularly of the provincial government, refuse to acknowledge the humanity of people who use drugs and succumb to stigmatizing them as somehow deserving less than the fullest care that we can provide so they can live their best lives, just as we try to make sure everyone else can live their best lives. It's horrifying, it's uncivilized, and I'd like to extend, my apologies to the community who are struggling with this, that we haven't done better, and to recommit that we will do everything in our power. It's the least we can do. Thank you.
Thank you, Councillor Perks. Let me open up to, Any other members of the board wishing to speak on this item? And I'd just note, welcome Councillor Lai, who has just joined us, a member of our board from her first meeting as a TTC commissioner. Welcome, Councillor Lai. Any other members to speak on this item? Okay, seeing none, I will put myself down here as the final speaker. Let me begin by placing an amendment, and I'll summarize it briefly. First, and I'll speak to this in greater detail shortly, is to report back on the status of the conversations with the city, with enforcement agencies, with the federal and provincial governments on decriminalizing the simple possession of drugs for personal use. Of course, our first recommendation from the Medical Officer of Health is to request the Minister of Health to immediately decriminalize the small possession of drugs in our city, and we will be advocating for that, and this is to ensure that we, within our own city and with the other governments, are staying on this. The second is for the Board of Health requesting our MOH and the General Manager of Shelter Support and Housing Administration to continue to work to expand, to urgently expand overdose prevention work and other harm reduction measures across our shelter system. That the Board of Health requests the Minister of Health to reinstate funding for the OPS sites operated by Street Health in St. Stephen's, to request the Minister of Health to expand naloxone distribution to allow service providers to administer naloxone to clients in their programs, and also to request the collection and public reporting of socio-demographic data on fatal and non-fatal overdoses in our city. And so I'll place those amendments and of course we'll move the staff recommendations in front of us. Let me begin by thanking certainly our staff in the Toronto Public Health Drug Secretariat. We heard from Nicole earlier and the whole team for their continued work, and as well from those who are working on the front lines in the harm reduction community and those who use drugs. And we heard from both frontline workers and people who use drugs here today. Your work is life-saving. It's it's life-saving, it's trauma-creating, it's painful, it's necessary. It's work that we cannot thank you enough for doing. And it's work that, as you bear the burden of seeing collective intergovernmental inaction, that you do without the feeling of response as is required. And so I want to thank you. Every month since COVID has began, nearly every month, the overdose crisis has been worse than the one before. The stats were presented earlier, and it almost feels like you trivialize the gravity of the situation when you talk about numbers, because we're talking about people, colleagues and friends. But the numbers paint a devastating picture. 132 deaths that we know of due to overdoses between April and September. That is higher, 85% higher than the year before and the year before that. And so we know that this crisis that has an emergency that has existed for years has been magnified deeply by COVID. And to the question I think that many deputants have asked, that we must all ask ourselves, including those of us in government, is, to put it bluntly, how many people must die before governments give a damn? When I ask myself that question, part of the answer is that stigma kills. That somehow the stigma associated with drug use continues to lead to inadequate responses. And as a result, when we talk about the work necessary to confront the overdose pandemic, when we talk about a public health approach that scales up safe supply, that funds harm reduction and treatment properly, that is coordinated through a task force with the urgency that this entails, just like COVID, that finally and truly confronts the legal issue of drug possession. That as we address all of those policy measures and necessary responses, we also must acknowledge that this is rooted in stigma. And I will tell you that for me, when we look at our city's role in response, just as we are here to advocate and implement, I think it is fair to say that regardless of our jurisdictional role, whether we are a provider or not of healthcare, Simply pointing the finger at other levels of government isn't good enough. And it's to that extent, just like as in the shelter system, where we heard that our city divisions are currently providing funding for healthcare and harm reduction in the shelter system. If that's what it takes, that's what we must do. And we must, as the motion here speaks to, expand that. Should it be the provincial role? Yes. Should we demand that they do it? Yes. Should we fight for that to happen? Yes. Should we ignore it and wait until it does? No. And so that is the work. And we have no choice but to act. But fundamental to this is a new legal approach. It is a recognition that you cannot, arresting people for using drugs creates more harm. And decriminalization for small possession will come. It will come. The growing call across this country, whether it's from the Association of Chiefs of Police or prosecutors or public health officials or politicians, it will come. Our role as a board is to ensure that it comes sooner. Not to wait till the politics are right or that this is easy, but rather to make it happen as soon as possible. To make it happen now, and to do everything in our power to ensure that the federal government does so, because lives are in the balance. And so that is the work in front of us, both today and going forward. And the reason, to be very clear, that our First Amendment speaks to a report back on the status of that work is because it is not acceptable to talk about this, to pass motions, and to talk about it again. The urgency and the emergency demands, and the people in our city demand better than that. With that, I'll conclude my remarks. And thank you once again to our staff in Toronto Public Health and in the Drug Strategy Secretariat and all of the frontline workers. Thank you. Okay. We have an amendment. We have a series of amendments. We have an amendment from Councillor LongTerm on expanding grief and trauma supports. All those in favor, by way of a show of hands. Opposed, if any. That carries. Thank you. We have an amendment that I moved, and can I note I should have that this was moved in large part with Councillor Perks, the chair of our Toronto Drug Strategy Implementation Panel. My apologies for neglecting to mention that, as these recommendations came from the panel. So, Councillor Perks, my apologies for not mentioning that. So my motion being moved here, recommendations coming from the Toronto Drug Strategy Implementation Panel. All those in favor? Opposed, if any? That carries unanimously. And the recommendations from our Medical Officer of Health, once again, all those in favor? Opposed, if any? That carries unanimously. Members of the board, that concludes today's meeting. It was a long one, and thank you for the indulgence to work through to complete. Thank you once again to our Toronto Public Health staff and to our members of the board for being here today, and to everybody, stay safe. We have a busy month ahead of us. Thank you.